good. So good morning to everybody. It's great to see everyone this morning. Again, I thought yesterday was just a super meeting, really, really nice. So I learned a lot at it, and it was just great to see everybody, even if we're not all together personally. The other advantage was some of the people that may not have been able to come to an in-person meeting were able to attend. So that was really nice too. So this morning, we basically have three things this morning. So I'm hoping that we can encourage some discussion with each other, and looking forward to it. And we're really pleased to have as our first speaker, we're going to have Richard Nelson and Drew Ludlow. They've been working with us for a long time, and with Peter Harris, I know they've worked for even longer. And so we're really excited to hear the family perspective about MKD. I'd say the one thing, there are many things that bind us together as a group here, but the one thing that I've always been impressed by is that everybody in our group really cares about patients, you know, and I don't think that's true with all researchers. Everyone here is very patient oriented and really cares specifically about the people we're trying to help. So without further ado, Richard, I would like to hand it over to you and Drew.
That's great. Huge thanks to you, Tony. We met you through Peter Harris and Vicente Torres about 6 years ago. And through you, we met Anna. So this is great. I have 9 slides this morning to give a perspective from the patient and family viewpoint. I'm going to use a small portion of what I presented 3 years ago at the Broad. I want to talk about the Nelson family and the Rare Kidney Disease Foundation and helping to accelerate a treatment after a 30-year search. I would hope that the comments that I make and then Drew makes will encourage and engage the patient community. This has changed my life over the last 3 decades. Deciding early on that we were going to go do something about this. And so this is the Nelson story. And I'm sure that there are many, many hundreds of these same stories. I would hope that you would come and be engaged with us. Next slide, please. This is a story about a young family in crisis. This is what my family looked like 30 years ago when I was 34 years ago when I was diagnosed with PKD, I thought. Polycystic kidney disease, and then got involved with the Mayo Clinic after that. It's a story about having your energy level at age 38, and Karen would be 5 years younger, and our 3 very, very active boys, trying to stay up with them when I had no energy. It was a very discouraging time in my life. I struggled health-wise, I struggled financially, I struggled in all ways. It was a very, very discouraging time having a disease that I had no idea about. We were, as I said, we were diagnosed with polycystic kidney disease. They didn't know about MUC1 or MKD or now TKD or even UMOD. Now, we didn't know what Tony was doing at that time. But in 1991, things started to change. And next slide, please. So going through this history of my family, I didn't ever know why my father had died so young. It was a little odd as an 11-year-old to see my father struggle and then pass away, leaving 6 children. My mother was 40 at the time. He'd been a very active, very much a hero in my life and many others. highly decorated in World War II, Guadalcanal, Solomon Islands. You know, he really had the best of things. He never disclosed to our family that he was ill, even though he knew he was ill. He was a young physician. He only practiced 5 years and passed away. We didn't know the story about why he was the only child in a family where his father had died at age, when his father had died when he was 5 years old. And we'll talk about the, you know, how this disease, this new disease that we've discovered, that you have all discovered. And I want to thank all of the researchers, the scientists for your incredible work over the years. Next slide, please. So 4 years ago, we had a family reunion. And it was on the shore of the great, a large lake in northern Utah and southern Idaho. And we had over 100 there. It was celebrating my father's 100th birthday. These are my 6 siblings. And I'll bring out a family tree here shortly and go through that with you. But on this is in St. Charles, Idaho. Current population, 153. That's a large headstone, as you can see, with my siblings there. And right next to that large headstone are 6 small headstones. And 4 of them, all of them are my immediate relatives, including my grandfather and 3 of his siblings and his father. And we'll talk about, let's go to the family tree slide. So Rasmus Nielsen comes from, my great-grandfather comes from Ring, Denmark. And he was apparently the carrier of this mutant gene. And he had 5 children, including my grandfather, Andrew, and then on down the line to my father, Roscoe, and me. But he had 5 children, and of those 5 children, next slide, dates, you can see the age that they passed away. You start doing your family history, and it reveals remarkable things about what's going on in your family. So you can see that the 5 children, 4 of them died, or 3 of them died in their 30s, including my grandfather at 37, and his little sister died at 26. What's interesting is we work very closely with this, with the extended family. I can see Tony's challenge of trying to get family members to care about this. Oh, it is painful, but that's the challenge today. And it's made all the difference in my life, living a full, active life. You see, my father died at 43, and I'm well over 43, and I don't plan to go anyplace soon, and I'll tell you the rest of that story. Next slide, please. So it's, this is a story about an older brother. It was in that slide, it's in St. Charles, who didn't have this mutant gene. Who was a visionary, who cared deeply about the family. He was 16 when Dad died, and he took me aside shortly after I had an incredible transplant. In fact, let me insert that as a big part of the story. When I was 38 years old, I started to slow down. And I couldn't figure out why. People had talked about being over 40 was kind of the big time in life that things change, and well, that had nothing to do with it. I had this cystic kidney disease that ended up not being in the same family as polycystic kidney disease. And I was extremely fortunate to be on a transplant list. At age, I was on a transplant list when I was 41. And I was only on there for a short time. And back in those days, 30 years ago, there were only 19,000 in the pool that were trying to get a cadaveric kidney from someone who had passed away. And we ended up, our family was incredibly blessed. Again, I had 3 small children at that time. And one morning early on a Saturday, I still can remember that 7 a.m. call. I got a call from the transplant coordinator that said, "We've got a kidney here." Well, was I interested? Yes. This was a call from New York, where I have an apartment right now, even though I'm living in Utah during this virus. And it's, you know, that call has changed my life. There was a 17-year-old girl who died of a brain aneurysm on a Friday night. They looked at all the patients around the country, and I had a perfect match. And so they were willing to fly that to Utah, where our family was and is, and I was transplanted. It's, I can't tell you, and you know, the emotion that you go through when you get your health back, get your life back, and that's what the patient community has experienced and is hoping to experience. That really is the only solution at this point. I'm beyond enthusiastic about the scientific and research community that has pushed a treatment and you know, effectively a cure forward over the last number of decades, because that really is the solution, even more so than transplantation. I have 5 children. They have 16 cousins that have been affected within those 4 families. And so effectively we have 10 or 11 kidney failures, hopefully kidney transplant, really hopefully treatments, you know, that there will be a treatment for them as they come up. They're from 38 to 23, and hopefully they will have a much different experience than me. At least 2 or 3 of them, along with their cousins, and then we have grandchildren too, 5 of them. So this is what I've discovered in this community. I didn't know about a transplant community. I love the transplant community. I've served in the community. I got involved with my local National Kidney Foundation. You show a little interest and all of a sudden they put you into leadership. I became the president of that. And one thing led to another, and I found the Mayo Clinic early on by going to a PKD national conference. I attended 10 of the next 15 of those. And that's where the first meeting I met Vicente Torres and Dr. Torres and Ted Steinman and Peter Harris, who were really some of the early pioneers in this, and not just pioneers, they're continuing to push forward. And so we started to get involved, and we had all of our children tested at the Mayo Clinic at our expense. And but it was really the NIH, and it was tests along with the vision of Dr. Peter Harris and Dr. Torres that allowed us for over 20 years to be involved with all kinds of tests. We were willing to be tested. We decided somebody needed to move this forward. This is what I discovered from that small group of support that continually grew. And now I'm thrilled that 52 of us are on here right now. Yesterday we had up to 87 with the scientific group. But Margaret Mead said the following, and it is absolutely about our community of patients and patient families and scientists and researchers. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. Next slide, please. Drew will mention this at the end of towards the end of our time. So an older brother challenged me, we need to get involved. You know, and again, I struggled financially in those days. I didn't have the means to go to 10 conferences, but he underwrote me and he basically said, you go and our family needs to be part of the solution. And that's what we've tried to do. He was a visionary. And then I had an older sister that Drew will talk about, his mother, and who was really the spiritual motivation. She would pray and fast every time I would go to these meetings, especially the first one where I met Dr. Torres and Steinman. So we created a rare kidney disease foundation. We need to do something. And we invite you to come and be involved with our community. Next slide, please. This is how I feel about this community at this point. It's not about someone else, it's about us. And it's about the 52 of us that are on the line now. I mean, 2 years ago when Anna and Tony decided to have a family summit, family day. I think it was Sunday, October 21st of 2018. We got together, about 40 of us, two research groups, Stan from the Czech Republic and his team, and Anna's team at the Broad Institute, and then a number of patients. And I love the way that Anna and Tony keep talking about, this is all about the patients. This is driven by the patient. That's why we're doing this. And so this is how I feel about our community now. And again, we invite you during this time together to think about and then to find a way to be engaged. And we'll give you a way to do that. And Drew will lead a discussion about that this morning. Never doubt that a small group of thoughtful, committed scientists and patient advocates can change the world. Indeed, it is the only thing that ever has. Next slide, please. So going back to Bear Lake and our family celebrating my father's 100th birthday, I'm sure he would have loved to have been there. And in our belief, we feel like that he could look in and see over 100 of us, 6 families, over 100 of us there. But this is the challenge. With your engaged help, and frankly, only with your engaged help, there will be a treatment this decade. And Anna will speak to this, and Tony will speak to this, about the small, ultra-rare disease of MUC1, MKD, mucin 1 kidney disease, all one and the same. We need a larger group to go forward, and we'll go forward, with the leadership of the Broad and Wake Forest, but especially the difficulty of getting a treatment, a compound. I mean, there is enormous optimism and reason to be hopeful about the disease that we have inherited. The Broad has a compound, and Anna will talk about that. And I'm absolutely convinced in this decade, we will have a treatment for my 5 children, essentially the 2.5, 3 of us, 3 of them, to benefit directly from that. And with that, I want to have Drew Ludlow, my great relative, my great co-founder of the Rare Kidney Disease Foundation, and really the facilitator of the Zoom access of this conference, to make some statements as we conclude.
Yeah, thanks, Richard. Richard, because Richard's been doing this for such a long time, I mean, I think it's really been an inspiration to me to kind of see how he's dialed in what really matters in this. And it's been incredible just these last few years as he's kind of invited me to come along and kind of engage with so many researchers and go to some of these technical conferences where it's like I'm picking up, you know, every 5th word maybe. And this is what I wish we could have at this summit, and hopefully we will in the future, have those hallway conversations. And I think about some of those hallway conversations that we've had at the Broad, at Wake Forest, where, you know, a researcher pulls us aside and said, well, let me just show you this. You know, this isn't quite, we're not quite ready. We don't quite know where this is going to go. But when we first kind of heard these rumblings about a potential treatment, it was so incredible. And what we hope is that we can put, and again, I know you wish there was a more attractive face to put on the patient community than us, but we hope we can put a face on the community and help everybody realize, like, this is why we're doing this. Like, I can't imagine, I'm not a scientist, I can't imagine what it's like. I'm sure in many ways it is the ultimate, you know, puzzle of a lifetime, but I can't imagine what it's like to spend hours and weeks and months and years trying to solve a problem in maybe a windowless lab. And we hope that, again, we can maybe put a face to that and be exceedingly grateful for what everyone is doing. It really means the world to us. So we started the Rare Kidney Disease Foundation, as Richard said, 2.5 years ago. My mother, Marcia Ann Nelson, and she married my father, Bob Ludlow. She was in that picture, and in 2016, next to that headstone, and then she died just a little over a year after that. She died in 2017 after being on dialysis for 20 years. She had 2 failed kidney transplants, had gone through IVIG and tried to bring her antibody levels down, but she'd had a blood transfusion when she first got sick. But she endured, she was on dialysis for 20 years. And was a real, as Richard said, real spiritual force of nature. One who could, I mean, the willpower, and somehow, like, you just ask her to pray for something and all of a sudden it's happening, and it's like, oh man. And so we thought, you know, how can we, and obviously it's been very difficult to lose her. And we're glad that her life was extended as long as it was, but it was very difficult. And so we started this foundation in part in her memory, and in part to hopefully do something to prevent the incredible suffering that she went through for those 20 years. And I mean, there are many, many hospital stays, and we spent a lot of time in those hospitals. And so how can we prevent that? For 4 out of these 6 siblings, it was Richard, my mom, and 2 others. 4 out of the 6, more than 50%, had this disease, and 2 others are still living, and 1 is probably not going to be with us much longer. And so we think, how can I make sure that we do everything we can to make sure that, my cousins, my generation, and then the next generation, and again, there are so many families, probably far more than we realize, that are experiencing this as well, don't have to experience the same thing. And so we're thrilled to be a part of it. We want to galvanize the patient community even more than we have in the last couple of years. We've started just having a few, you know, we did a breakfast in San Diego at the ASN. That was kind of our first little thing. And we just want to be whatever we can be to help. If it's running a Zoom, we'll be there. If it's you know, convening a meeting, we'll be there. And we want to hear really what the researchers and collaborators need from the patient community, and we'll go out and get it done. And again, and hopefully doing so not with, we want to be aggressive, but we also want to do it in a very grateful and collaborative way, because we truly are just exceedingly grateful to all of you researchers on the call. It was, again, so incredible to listen yesterday to the progress that's being made in countries all over the world. So thank you so much. Really appreciate all that you're doing. And we want to be along for the ride. We're excited to see what comes in the coming years here. And with that, I think I'll throw it back to Tony.
Well, thank you very much. That was very poignant and touching. Every time I hear that, it just invigorates me, and I'm sure the other clinician researchers and scientists. And so thank you guys. I always say, we need three things. We need patients, we need scientists, and we need clinician researchers, because those three, without each one of them, we're not going to be able to accomplish our goals. So yeah, so that was really great. Thank you guys very much. So now, hold on, let me see. So yeah, I'm going to go ahead and I'm going to start, and I'm going to do my talk about family history right now, or not family history, natural history of disease, which is basically, as you guys said, I spend a lot of my time working on this. And hold on a sec, let's see, I gotta get this. Let me see if I put this over there. I don't know why it's doing the slideshow that way. Oh, I guess I can share my other screen, right? Let's see here.
Hey, Tony, as you're teeing that up, one comment from Martina yesterday, and also Anna, was the powerful collaboration as Martina concluded her comments. That's really the only way this is going to move forward, and is moving forward. But anyway, back to you, Tony.
All right, okay, let's see if I can get this now going. All right, so you guys see the agenda now, and now you see the slides, is that right?
No, we don't see anything, unfortunately. There's something about the two screens, I think, that
All right, okay, all right, hold on. All right, well, let me just go ahead and screen two.
The one thing that I did want to comment on, Richard, just to follow up on your comment while Tony's bringing his screen up, is that I think for sure collaboration is the key here, and especially now, since we have a very real chance of developing possible treatment to manage this disease. We're going to need patients for the clinical trial, and we're going to need the advocacy with the regulatory authorities. Tony and I can paint the picture of what the disease looks like, which Tony's about to do. He's the world's expert, I would argue. There's so many other colleagues around the world who could do the same, painting the picture of what the patients are going through, but nothing is as effective with the regulatory authorities as the patients coming with us to the meeting, which we hope to have many of you, not only MKD, but also UKD, uromodulin kidney disease patients, come with us to the meeting. It may be a Zoom meeting, but nevertheless, come to the meeting and really tell your story in your own words. That turns out to be, of course, much more authentic and more effective. And that has been true for many other rare diseases. And we hope that it would be true for this one as well. So this is not just to, kind of a theoretical idea, but it's really a very practical ask that we will have to do over the next couple of years in order to be able to bring this to the next level, this possible treatment. So we definitely need partnership from patients, and not just in the United States, but all around the world. The more we can present this as a movement, the more likely we are to to move the authorities and to convince them that this is really something they need to think very carefully about.
Tony, if you uncheck right where you just were, if you uncheck use presenter view, you should be good to go.
Where is that?
Go back
Under
to slideshow.
slideshow?
And just uncheck use presenter view.
Oh, all right, okay, good. All right, good. So then I can just do the slideshow now, hopefully. Oh, perfect. Thank you, Drew. All right, so very good. So let's get started. And Drew, you're right. Our lab is a windowless lab. That's a long story. But anyhow, so this is our medical center at Wake Forest. And so what I'd like to do, first of all, just thank everybody who's worked with us over time. It's just been truly incredible to be part of such a really, really great team, Anna and everything that she's doing, and all our collaborators everywhere. So I'd just like to say that. So we're going to talk about the natural history and the road to clinical trials, risk factors for end-stage kidney disease, variation in eGFR decline, and we have time, I'll talk about the vitamin D trial. So why is natural history important? And what I'm talking about is a progression of kidney disease, because that's really what we're looking at in this condition. And so for the patients, it's really important for planning. If I diagnose someone who's 22 years old who has a normal kidney function with a UMOD or MUC1 mutation, they want to know what's going to happen in their future. If it's a young lady, they want to know, can I have children? So these are questions, so that's really important for the patient to know, have an idea of what their future will be like. For doctors, it's important to know how the progression of chronic kidney disease will be, because there could be deviations. Patients could have acute kidney injury from something else during the course of their disease. So it's important for doctors to understand how the disease is progressing to spot these things. And then something that's really, really important, and I shouldn't say know when to plan dialysis, but plan for transplantation. So because we really want to be able to plan for transplant, that's our key. And for the investigator, for us, it's critically important. So one thing is we want to be able to plan clinical trials. And to plan clinical trials, we need to identify patients who are at risk of progressing. If we have 1,000 patients who are not progressing and put them in a clinical trial, we learn very little. So we need to spot, on the other hand though too, if we have patients who have progressed too far, then a treatment is unlikely to work. So we have to find that sweet area, and we have to understand the progression in order for us to be able to perform a trial. And something else that we've been looking at recently is if we can identify patients who are at risk for progression, we can study their biomarkers early on. And biomarkers are markers of disease activity. It's a very important topic in almost every disease. How can we predict when disease is active? I say the serum creatinine is like, or the GFR is like an odometer on a car. It measures the miles. But a biomarker is like the speedometer. It tells us how fast the disease is going. And that's what we need to find for this disease. I think this slide, unfortunately, encapsulates about everything we know. And Kendrah knows this slide very well. We call this our favorite slide. And so each one of these is a family. So each column is a family, in this case with MUC1 disease, and on this side with UMOD. And each column is the age of end-stage kidney disease. And so you can see for family 1, this was our earliest family. Patient went on dialysis or needed a transplant at 15, and someone at 28. And we can see that there's basically, we feel like a group of families that have a somewhat younger age of onset of kidney disease. And then we have a second group that have a somewhat later onset in some family members. But if you look, even at this family right here, it's just amazing. Someone went on dialysis at 15 or needed a transplant, and someone at 80. So why I just don't understand, why can there be such a variation in age of onset? And when we do our studies, as I'll show you, we're looking a lot between families. We'd like to explore better within families what this difference is, but that's very, very hard to do. If we look at UMOD, we see very much a similar thing with UMOD as we do with our MUC1 families, just this tremendous variation in the age of onset of kidney disease. So we're going to talk first about risk factors for end-stage kidney disease. And here's a paper by Eric that we worked with. It was really a pleasure to work with everyone in this group. And as Eric noted, I'm just showing this slide showing here are the patients with UMOD, ADTKD UMOD, and this is their survival, freedom from end-stage kidney disease. And this is a time to end-stage kidney disease. And we can see that patients with the UMOD disease have a later age of onset of kidney disease than patients with the MUC1 kidney disease. This is, of course, variable because some families with more severe mutations in UMOD may go on dialysis earlier. But if we take all of the patients that we have from all of our studies, this is the data that we have. So this paper just got published 2 days ago, and it was a great work together with many, many different groups from all over the world, many of you who are on this call. And started with a hypothesis. So there's a SNP, a variant, that's present in the promoter region right here, so right before the UMOD gene. And the SNP, there can be two different alleles. There can be two different nucleotides at it. And the A is present in 81% of the population, and the G is present in 19%. And so the G allele, which is present in 19%, decreases UMOD production by approximately 50%. This is from the study by Dr. Trudeau, which include Olivier Devoost and Luca Rampoldi and Celine Schaefer. If you guys haven't read this study, this is just absolutely incredible. And it's really a fantastic study. So, but what this study shows, right, or what we know is if you have this promoter, the minor allele, in front of the UMOD, it decreases UMOD production by 50%. So we hypothesized that since the SNP is in the promoter, or well, we know, since the SNP is in the promoter, it will always be inherited with the mutant UMOD gene in the family. So all patients with UMOD have a mutant UMOD gene. And they also have a SNP in their promoter, just like the SNP in the promoter, the wild type, and it's the same. And we hypothesized that if the SNP that's with the mutant UMOD is the minor variant, then it will decrease production of mutant UMOD. So let's look. If you have the SNP, the A SNP with the mutant UMOD, because it's on the promoter, it's in linkage disequilibrium and will always be inherited with this. So a child from this family will get, if the child has a disease, they will get this SNP with the mutant UMOD, and then they will inherit from their other parent either this SNP or this SNP. So in such a way that the mutant UMOD will always have the same SNP, but the patients will have on their alternate allele different SNPs that are the same as in the general population. So our hypothesis was when the minor variant of the RS4293393 SNP precedes mutant UMOD, there will be a 50% decreased production of mutant UMOD, resulting in milder severity of disease. And so we proposed to do a Mendelian randomization study, which means that we believed that this was just random through the population, this SNP, and that we would just collect data on patients as to the age they ended up with end-stage kidney disease. So this would be similar to giving a drug from the moment of birth that would decrease production of mutant UMOD by 50%, and the drug would never be missed. So we received a small NIH grant to study this. And to do this, as we said, there's only 18% of the patients will have the minor variant. So we need lots of patients and lots of families. And so this was really a testimony to our international colleagues who really helped us a lot with this. So we had 580 individuals we screened from 129 families, and we found 400 UMOD genetically affected individuals. And we also had 254 individuals we could tell from the family tree were historically affected. And from our colleagues, we received 349 individuals, 322 had UMOD, and there were 120 families. We had more clinical data on the Wake Forest side, but we had genetic data on both sides. So the first thing that we had to determine was, are the alleles, are these SNP variants, the minor variant, is it present in the same proportion of the population as in the families as it is in the general population? So in the general population, the allele frequency, so this minor allele frequency in this SNP is 18, 19, or 20%. When we looked at this allele, the alternate allele in patients who had the disease, so this is the allele that they did not inherit from the affected parent, and so this should just be like the general population. We saw the observed minor allele frequency was 17%, which was not statistically different from what we would get from the general population. However, when we looked at the mutant UMOD allele, so when we looked at this allele and we looked at the allele frequency, we would have expected it would still be 19%. But instead, we found that only 12% of the families were linked to the minor variant, which was a variation. So we should have had 18% have the minor variant, but instead only 11.6% had it, which was statistically different. So in other words, there was something that was driving this, that we had a variation in outcome, a variation in frequency of this. And so this meant, this is what's called Hardy-Weinberg equilibrium, and this was not preserved. And so what this means is this was not randomly found in this population. So why were there less families linked to the minor variation? And we think the reason for this is we think that the disease is milder if you have the minor variant. And so patients with the minor variant, some of those families may not go on transplant or dialysis until they're 75 or 80 years old. And so we feel like those families we were likely to miss in our study, or they're missed being recruited. And so that's why we did not have as many families with the minor variant. And because we did not have these families, we could not perform them in the Delian randomization study. And another problem we had was we already had a low frequency of this variant, 18%, 19%, but now it dropped to 11%. So only 11% of the families that we studied had this minor variant, so we didn't have enough information about them. If we look at the survival of these groups, we can see that patients with the minor variant appeared to possibly have a little bit of an improved survival, but we're only looking at 41 patients. And by this time, there were only 9 patients left in the cohort. So unfortunately, we were not able to prove or disprove this hypothesis, though we did show that there was a decreased frequency of this allele. Now, when we did the genetic analysis, we also needed to account for the family structure. So we had one family with a 27 base pair deletion that's very common in the US that made up about 40% of our patients. And so if we had that big a difference, we had to account for this. And when we accounted for these within family statistics, it decreased our power. One thing we did find in the study that was very interesting was the gender effect on survival. And if we look at the median survival to end-stage kidney disease, we can see that for women, or for men, the median was about 50 years, and for women, it was about 57 years. So women survive longer with uromodulin, with ADTKD UMOD than men. And this is common in many diseases. So many kidney diseases, women do better than men. Now, Celine Schaefer and Luca Rampoldi had a great idea, which they had been working on before our study. And this was to develop an in vitro score. And their in vitro score looks at the amount of, so we have two alleles making neuromodulin, and one is mature and one is normal, and it should be able to secrete the neuromodulin outside the cell. And the other one is damaged and stays in the endoplasmic reticulum. So they developed an in vitro score where they put these different mutations into cells, and they looked at how much normal neuromodulin got out of the cell and how much mutant neuromodulin was stuck in the cell. And when they did this, they came up with 4 categories just by sight. They were like, wow, there's really 4 different groups. And there's one group, when they look at this, that almost all of the neuromodulin is mature and it's secreted outside the cell. So these would seem to have a milder in vitro phenotype. And these patients were intermediate, or these patients was half and half. And in this particular mutation, almost everything was stuck in the endoplasmic reticulum. So we looked at and Luca has a big retreat of his whole department today that he has to present that, so he couldn't be here, unfortunately. But if we look, and we call this the Luca score now. But if we look at this, the outcome by these scores, so the in vitro score for the patients what looked like the milder, right, that had most of the neuromodulin excreted, they have a much better outcome with a median age of end-stage kidney disease of about 64, whereas patients with the higher in vitro scores where it's retained, they have a lower mean age of end-stage kidney disease. So the in vitro score is actually is a nice thing to have, because you could have a family that has a new mutation, and Luca would be able to determine a score and give us some idea about the age of end-stage kidney disease. In our final model, when we looked at the final model just for the genetics, we saw that the in vitro score and gender were very big predictors of the age of end-stage kidney disease. And when we looked at a multivariate model for the Wake Forest cohort, we saw that gender and family mean age of end-stage kidney disease were significant. We were very happy to have the large population, but we were a little disappointed that we didn't find more variables that were predictive of end-stage kidney disease. One thing that we did do was we were able to put all of the mutations together, and this is available at this website. And let me just bring it up for you right here. So if you go to our website, this is a UMOD mutation registry, and if you have a new mutation, you can go ahead and enter this. And then here is our mutations. This will show all the mutations. And so, for example, if you have a patient that has a mutation in this amino acid, say 50, and this is the nucleotide change, and it's a cysteine to a serine, we have the mean age of end-stage kidney disease for this. We have where it occurs, and we also have the in vitro score available when available. So for anyone who has a question, if they have a new mutation or they have an old mutation, you're able to go ahead and get on this. And we also have all the references of all the articles that have been published. So we're hoping that this will be very useful to everybody. What about end-stage renal disease with MUC1? Again, so aggravating, the same thing, and this variation of age within families themselves. Now, MUC1 also has a SNP in the promoter. The SNP changes the splicing of the MUC1 promoter. There's a short splicing SNP, SSP, which makes for shorter MUC1, and then there's a long splicing SNP. These have been studied in various diseases. The good thing about this SNP is it's present in 45% of the population. And when we look at the long SNP, we find that it's most likely related to hypomagnesemia. It lowers your risk of gastric cancer and increases your bone, is associated with a higher bone mineral density. What about in our population? So we looked at the same thing as we did before. 45% of the family should be SSP, right, because that's a minor allele frequency. And we find that only 14% of affected families have the short splicing SNP. We don't think that this, you know, in terms of treatment, this is not going to be a big factor. We need to treat both diseases. But in terms of helping us to figure out which people are at risk of progression, we believe that this could be helpful, and we're doing further studies on this. The SNP is also associated with a shorter VNTR length. So if you have the SSP, you have 2 copies of it, you have a shorter VNTR. And if you have the LSP, you have a longer VNTR. So of course we hypothesize if you have the SSP, you have fewer mutated VNTR lengths, and that may be associated with the progression of disease. And we're actually actively studying that right now, and we hope to have results on that for the next meeting. We look at survival, again, we didn't really have enough families, but there's some hint of an improvement in survival with the SSP. Now, then we took all of our data together and we looked at the age of end-stage kidney disease by gender and by disease. And so the people with the best survival are women with UKD, or ADTKD UMOD. Then the next best survival is men with ADTKD UMOD. And then, so most diseases, most kidney diseases, women survive better than men. But that's not the case in ADTKD MUC1. And in ADTKD MUC1, we see the females, especially between 20 and 40, have what seems to be worse survival than the men. So this is a question. Why is this happening? So one thing we're interested in is, could this be related to childbearing? And so we've started a study on this. If we look at plasma MUC1 levels in pregnancy, we see that they're significantly elevated in the 3rd trimester compared to the 1st in 2 studies, and 1 study showed they're about 10% above normal. So now, does this mean there's more MUC1 produced in the kidney during pregnancy? We don't know the answer to that. It's going to be very hard to answer that question, but it would be something we'd like to think about how to study. So in summary, the SNP variants linked to mutant MUC1 or UMOD may affect survival, and we've seen this change in women versus men for UKD and MKD. Our action item is we are actually now conducting a study of maternal health and outcomes in ADT MUC1 and ADTK UMOD. So Richard, you know, and Drew, so this is a question, right? You know, we get a lot of, I always say, you know, so we do all the, through the Broad, we are able to send all of our samples, thank you, Anna, to the Broad for testing. But then every person who's positive, I call back myself. And so that's always a sad day for me to have to make these diagnoses for families. And a lot of times they're young women and they want to know, you know, can I have a baby? That's a question that I frequently get. So to solve that, to look at that, we're looking at the maternal health and outcomes of women with ADTKD MUC1 and ADTKD UMOD. We've created a RedCAP database survey, and we have 140 women that have answered so far and that we're going to look at outcomes. In general, in kidney disease, if you have chronic kidney disease, the outcome, if you look at the studies, the outcome for pregnancy, there's always a high risk when you have mild CKD. But I wonder if that may be due to glomerular disease, and these studies don't seem to account so much for patients with tubulointerstitial disease like our cohort, especially the UMOD patients who don't even have high blood pressure. I was surprised when I was going through this that I haven't found a really good study of maternal health and outcomes in polycystic kidney disease. And so I was hoping maybe we could collaborate with Marie and with Peter and see if we could use this survey in a large group of ADPKD patients as well. Now, so there's end-stage renal disease risk factors, right? But that's not the same thing as eGFR decline. And so the method of decline is also important. And so here's a study that we did some time ago, and this is eGFR over time for different patients. And you can see that when the GFR gets to below 60, patients tend to decline quickly no matter what age they are. And we found that patients who have a GFR greater than 50 have a GFR decline of about 1 ml per minute per year. And when the GFR dropped to less than 50, it was 6 ml per minute per year. This has actually changed. It's lower now after we have more data. So let's just assume, and I think we can assume that GFR at birth of these patients is normal. That's something else we're looking into. But assuming their GFR is normal at birth, we develop these curves where, or not, I shouldn't say curves, but these trends. And so then here's the question, where do we want to intervene? If we intervene, say, in these patients, their rate of decline is so low that it would be hard to have them in a study. If we intervene here, they may have lost too much kidney function. So this is something that we're working on. We're really going to try to study the rate of GFR decline. We basically try to steal everything from the polycystic kidney disease literature. Thank you very much, Peter. And I think Vincent, I think Marie's on this too. One of these, I know she's on. So if we look at they calculated their trajectory of GFR decline, and they did this by kidney size, the Irascibel classification. So of course, we don't have that classification in our patients. But what I found interesting was how they're looking at the slope and how these trend lines are, which is somewhat similar to how ours would be. So I'd like to see if we can look at a more curvy linear modeling. So how are we going to model decline? So I'm hoping that maybe we'll be able to look at these studies and maybe collaborate with some of the statisticians and investigators. The PKD HALT trial also looked at changes in kidney function over time. And about 50% of the patients had what we would call a linear decline in kidney function over time. But just like us, there are some patients, they go down and then they stay stable for a while. And some patients, it's kind of undulating course. And so this is really difficult because it makes it hard if you get into a study where, you know, your kidney function was declining, but then it's stabilizing. You know, what if we put a person in a study right here? Well, gosh, it looks like, man, their kidney function did really, really well in the study, but it could be just that they were going to stabilize. So an action item for us in this is to see if similar analysis can be done with our patients as was done in the ADTKD cohort. I can be in touch with Peter and Marie about that as well. We're also doing a study where we show serial follow-up of 33 patients. We have like 40 patients now that we're following serially, or Kendrah, I would say even higher, maybe 50. So we're just getting labs every 3 to 6 months on them. And we're following the GFR, and we're also getting biomarker samples. Something that's really important that I've learned in the last 2 years is that the decline in GFR after you get to CKD3 is about 3 ml per minute per year. And as we talked about, one thing is we get a lot of referrals actually when the GFR drops to this level. Now, in the US, you can get on the list for a transplant when your GFR is 19. And dialysis usually starts when your GFR, or it should start when your GFR gets to be about 8 or 7. So that's 4 years you can get on the transplant list. And so 4 years on the transplant list, you're pretty close, at least in North Carolina, to getting a transplant. So our goal is really to have living donor transplants for all ADTKD patients, and if not living, cadaveric. And I can tell you that I firmly believe the absolute best disease for kidney transplant is ADTKD MUC1 or ADTKD UMOD. PKD is great, but there's a problem with the size of the kidneys. We don't have that problem. We don't have aneurysms. We don't have cysts in other locations. All we have is this kidney disease. All it affects is the kidney. And so it's really patients with this disease, and as our Irish colleagues have shown, do extraordinarily well with transplant. Just very quickly, we're really trying to help patients find donors. We have a webinar on CKD and ADTKD that we did that we had a lot of people attend, and it's available online now. Another thing that I really encourage is getting on Facebook. It's really difficult to ask someone for a transplant, right? And you can only ask 10 or 15 people maybe. But a lot of people who donate turn out to be people who just want to do something really good. And they may not even know you that well. So we've had about 5 of our ADTKD patients that I've been in touch with have gotten their kidney literally by posting on Facebook to their friends and asking about if there are any donors. I actually had a patient who was in the hospital, didn't have ADTKD, but I was on service last week, a young lady, she's on peritoneal dialysis. And I said, well, what about living donors? And she said, I don't know how to do it. I said, you need to post on Facebook. She posted on Facebook. I went in the next morning. She said 3 people volunteered to donate. So it's been an important thing. And so that's our goal, to have living donor transplants, and also to avoid the rush to putting these patients on dialysis. Now, something else we did was we developed a computer program that uses our available data to help patients to predict outcomes. So as I said, I get a lot of patients that we diagnose, and they want to know what their follow-up is. And so what I can do is I can put the age, I'll just show you like an 18-year-old who has a GFR of 95. So I can put her GFR in here. So she had 2 measurements at 20 of 100 or 2200 and 98. And then I made a group of patients. I said, anyone who hits in this box, I want to include in the GFR. So anyone who had a GFR from 80 to 120 between the ages of 20 and 30 were included. And this was the mean rate of decline for these patients. And none of the patients ended up on dialysis within 15 years. So that was a very helpful to our patient, to have an idea. It's also helpful in another way. I have a patient whose GFR was 60 at age 25. I tend to sugarcoat things, and it's known with doctors, they tend to be optimistic, especially if they like the patients. So this really gives me a reality check. So here's a patient we had who's 25, his GFR is 60. And so I took patients between 20 and 30 and a GFR between 50 and 70. And we can see that we had a number of patients went on dialysis. The average age was 31. At that time, 7 had gone on dialysis. So I can present this data, unfortunately, sadly, to this individual and let him know the outcomes. So our goals are to better understand the rate of progression. We're looking at biomarkers associated with progression. What we're trying to do is to break up our cohort into patients who have very mild disease. So for example, like John Sayer, the inversion deletion patients, to get urine on them and blood when they're young, and then compare patients with mutations like that to patients who have mutations with a 27 base pair, which is a more aggressive disease, and to look at them look at them all when they're young, and to see if there are any differences. We're interested in radiologic tests like MRI for fibrosis. The problem is these are expensive. They have to be done at one center. And we're waiting to see if there's a little bit more promise in those tests. Just quickly on the vitamin D trial. So the Broad identified that vitamin D, ergocalciferol and cholecalciferol may lower production of mutant mucin 1. So we administered 200,000, the hypothesis was administration of 200,000 international units of vitamin D will result in lower urinary and plasma levels of mutant MUC1. And we did this, and this was a great sign of our collaboration with our group in Cyprus. So we gave patients a dose in the US of Ergo, 200,000 units at day 0. We got labs at 3, 7, 10, 14, and 28 days. And these were where our groups were. So our patients were distributed all over the United States. Compared to Cyprus, we had 50 patients all in one nucleus, and they used cholecalciferol. Cyprus has 50 patients who received the drug. We had 21 controls, 22 MKD patients, and we have the study completed, and we're now awaiting results. Our goals for the year ahead include to model eGFR decline. We're really excited about our maternal health study. We have data on a series of biomarkers that we're waiting to get back from Harvard. We're thinking about a radiologic study, but it's expensive and difficult to do. We want to obtain more follow-up data. We're hoping to build the cohort. This is from our meeting last year at the ASN. I wish we were all together again this year. And I like Henry Ford. Coming together is, I shouldn't say I like Henry Ford. I like this quote of Henry Ford. Coming together is a beginning. Keeping together is progress. Working together is success. And here are all the groups that we work with. And so thank you very much. And so now I think we have time for a few questions. And then we now have like a good hour that we could talk through things. And we can also ask questions of our UKD, MKD families as well. Thank you.
I wonder, Tony, if we should maybe, if we don't have any questions immediately, I don't see any coming through in the chat, we should take the break now. And since we have such a big hour following this, if we should give people a little bit of a break and go into that, or what do you think?
Yeah, sure. We can take a break. That'd be fine. And then come back. People can type in questions. So we'll come back in like 10 minutes.
Yeah.
All right. Sounds good. All right. See you guys then. Awesome. Maybe I could ask, am I still on? Or I'm not muted. Oh, I guess we're all off.
Okay, Tony, I think we're back from the break. Oh,
Oh, unmute. Okay, can you guys hear me okay? So are there any questions? If not, I have a few questions.
so we do have some questions in the Q&A. And so I can even just kind of moderate these for you, and you can just go down. We have 7 questions.
Okay.
Maybe. What do you think is what do you think is the optimal age to test at-risk individuals?
Yeah, so this is a really big problem. So what we've done is we also have a webinar that we've done for testing. If any of you guys want to look at it and use it. So I think it depends. I would say it depends. So uromodulin, if you have a UMOD mutation, that's more severe. So like a 27 base pair deletion, and like some of our families, those patients can get gout when they're young. And so, for example, we had one young man we decided to test. We looked at his uric acid level. It was 10, which is very high. And he was an athlete, and he was pretty competitive. And so what we would not want to have is for him to get his first gout attack before some championship game. So if you're young and you have UMOD, then I think it's very reasonable to get tested. Now, MUC1 is a really different story because we don't have any treatments, and we don't have any treatments before age 18. The genetics societies, they advocate against testing until someone is over 18. So when we looked at testing, so we have our quality of life study. In patients we tested, even young patients we tested, now these are patients who wanted to be tested. We looked at patients who were tested, who did not know if they had the disease, and who we found out had the disease. So we're throwing out the 50% who did not have the disease, very happy, and we only take the 50% who found out they had the disease. And of those patients, 90, I think 95, one person was more unhappy than happy that they had been tested. But 95% of the patients were more happy than unhappy, and most of the patients were still extremely happy they were tested. The problem for me with testing after age 18 is that then the whole burden gets placed on this young adult who has enough things going on when they're 18 to decide what to do. So we get a lot of kids that get tested when they're 15. They have to give assent to be tested. They seem to be doing very well with the testing. So I think what I always say is the parent knows their child the best. If their child is a worrywart like me, probably wouldn't want to get tested. If the child is like, just really wants to know, I think it's reasonable. And then the only other factor that I really counsel parents on a lot extensively is that, okay, if your child has a disease, they need to be treated just like everybody else. So like you go to, the steakhouse Friday night, and you don't say to your child who has the disease, oh, you can't have what everybody else is eating. So, because we all know everybody needs to eat a heart-healthy diet. So that's the approach that we follow.
Great, thank you. Another question about the promoter variation of UMOD. Should we look for it in our genes panel? Can we use it as a prognosis factor?
Not yet. We're still working on this. It's really more of a research test, and it really doesn't help us to look at the age of end-stage kidney disease yet, which is what we're really hoping to.
In Portugal, we are studying patients with MUC1 in external labs like yours. Is it possible to offer patients pre-implantatory diagnosis? And do they have to go to Wake Forest if they can financially?
No, it's not possible right now. We don't have the ability to do that.
Do you anticipate the format of an upcoming trial to be similar to that of the vitamin D trial?
I think, so we're hoping in the future to have a trial, and I can let Anna maybe address this more. But what our plan is to take a cohort of patients, probably with GFRs between 45 or 30 and 60, and to hopefully use a medication and see what happens to them. And hopefully we're going to have a biomarker that we'll be able to use for the trial. So we're really, really trying hard to find the biomarker, but man, it just isn't that easy. And so that's the big goal. And a big problem that we have is measuring uromodulin gets excreted in the urine, and we can measure it easily. But MUC1 is actually attached to cells. So when it's excreted in the urine, and you guys can correct me if I'm wrong, but it's excreted on the surface of the cells. And so it matters how many cells are in the urine. And then a lot of the MUC1 comes from the bladder cells. So we're having trouble getting a really straight marker from the kidney. And so that's been problematic. But we're planning, we would get a cohort of patients. Hopefully there'd be a placebo. Well, there would be a placebo arm and a drug arm, and hopefully we'll have a biomarker that we can use.
Can I comment on that for a second?
Yes, please, go ahead.
Tony. Yeah, so Tony's right. We're working hard to develop a biomarker in the urine for both MUC1 and for uromodulin. For MUC1, we've actually, our team at the Broad has made great strides in detecting the very small amounts of MUC1 that is detectable in the urine in vesicles that can be found in the urine. And actually the purpose of the vitamin D trial was really to be able to test that both in the patients in Cyprus as well as in patients in the United States and see how well our measurements perform. You know, we do not necessarily believe that vitamin D is going to be the panacea for this disease. It has not proven to be the case for every other disease that it has been tested in. However, it was an opportunity to take a safe intervention and look to see, even if transiently, it might affect our ability to measure variable levels of MUC1 in the urine of patients. And so those data are being tallied up right now. And if we have good results from that, then we will be one step closer to having this long sought biomarker that Tony is talking about, which is going to be critical in order to perform a clinical trial. So just to sketch a little bit what a trial would look like, it would be in patients with relatively preserved GFRs. We don't want to go to patients who have lost a significant kidney function. So we will define this together with Tony and other specialists, and with basically the advice of all the physicians on this collaborative team. That's the point of this summit. But my current thinking is somewhere upwards of a eGFR of 40 or 45, as Tony mentioned. So people with preserved GFR, it would be a trial that would happen over a short period of time, probably over the course of months, measuring a biomarker, potentially inclusive of protocol biopsies. This is something that I really want to discuss with this community because I think that we might need to do that in order to define the amount of mutant protein that is in the kidneys of patients at the beginning of the trial and at the end of the trial. So we may need to go there. And so we will have the urinary biomarker, hopefully, protocol biopsies, a few months duration of taking a pill by mouth, right? In patients with relatively preserved kidney function. And we're hoping to be able to do the trial potentially in parallel for both MUC1 and UMOD patients. So we will see sort of how in the next couple of years this shakes out, but that would be the goal. We hope to do it internationally. Obviously, there are some logistical hurdles to that. It's also expensive to do it in multiple locations, but we're hoping to be able to get there. And that's why we need this community, because we need to collectively decide how we're going to be able to achieve this. So yeah, it's critical that we kind of continue our work with Tony and others here to develop this biomarker. We have to think about protocol biopsies. We have to have the patients available to be able to partner with us to do this trial. It's going to be in the form of a pill. My best prediction is that we are going to be able to start this, looking at the safety, not the efficacy, not how well it works, but how safe it is first, to give this medicine to humans. That's usually done with healthy volunteers initially, not with patients. And then you move on to, that's the phase 1 studies, as we call them, safety, Once you pass that safety, then you go to phase 2, which is efficacy. That's when we need patients. I think that we are probably at least 2 years away from the safety study is my guess at the earliest. And then, if our pill is safe, then we would be going into efficacy after that. But in the next, few years, we will be interested in launching a trial. And so we have to have these conversations now and plan for that in the next few years. So that's just my comment. We can have more of the discussion later in the day as well. I think it's critical for this community.
Thanks. So that takes us through kind of the questions, I think, kind of rounding out Tony's presentation. But we're now in a more broad Q&A. And so, especially for family members who've joined us, certainly collaborators as well, this is kind of an opportunity to ask anybody who has spoken, anybody who you kind of see on the panelist list there, questions about or concerns or express concerns that you might have. The easiest way to do that, there's a couple of ways. You've seen the Q&A function. If you see the Q&A button on Zoom, you can type that. You can type it anonymously too. You don't necessarily have to associate your name with it. You can also raise your hand. If you see the raise your hand above the chat function, you can raise your hand and we can actually allow you to speak as well. And so please, we have another a little over half hour to have these conversations. And so I actually maybe would start as those kind of come in, and feel free to, again, raise your hand or put a question in the Q&A. Just kind of following up maybe can you tell us what, we obviously heard a little bit yesterday about this, but we had this big publication about the compound last July, right? That was published. Has there been, aside from the work on the biomarker, has there been much change and obviously 2020 has thrown us all for a loop, and I'm sure that slowed things down considerably. Has there been much change since that publication in terms of, seeing efficacy or, using it in a different model or anything? Again, maybe it's not ready if it's not ready for publication, but anything since last July that's changed with respect to the compound for treatment?
Yeah, I'm happy to update folks. Of course, it is true that the coronavirus has slowed us down a little bit, but not a lot. And so I think our goals for this year, as Tony well knows, we're partners in this, are really to improve the compound to make it more like a drug, like a real drug that you can give to people, to humans. And so we are actively working with the chemists on the team to make this happen. And we are looking for the appropriate partners who can help us then bring that to the clinic, take it to the next level. There's a whole kind of formulaic process that needs to take place from the time that you, the kind of the steps that are involved are maybe for me to summarize the following. First, you do a screen, as we did in the publication, and you find a hit. We call it a hit. That means a compound that shows promise, has some properties. Then you do some additional screening to come up with a lead compound. That was also in the publication. That was the lead compound that we came up with, meaning it really looks promising and we really feel good about it. It has the promise of ultimately becoming a drug. So you go from hit to lead. Then the next step is lead optimization. So you take the lead and you try to make it more drug-like. This is the process that we're in right now, and we're hoping to conclude that process, later this year, early next year. So you optimize it enough to actually make it what we call a clinical drug candidate. So lead optimization to a clinical drug candidate. And then once you declare that step completed, we're not there yet, but once we declare that step completed, then we're going into what is called the pre-IND phase, which means we are testing this clinical drug candidate for everything we can think of before it enters a human. So there are studies that need to happen in higher animal species, for example, to test for how a compound is metabolized and whether it's safe and whether it has any unforeseen toxicities and things like that. So, we will have some work to do in that regard. So we are kind of in the lead optimization, hoping to declare a clinical candidate later this year. Then we will enter the pre-IND phase. The culmination of that will be the IND, which is an official filing with the FDA to tell them we intend to do a clinical trial with this drug. What do you think? And so this is the IND that we file with them. We will need all of your helps for that to happen, including the patients, to talk to the FDA and tell them how much this drug is needed, to convince them that this is a meritorious path that we are trying to be on. I will say that the FDA has been inordinately helpful to us so far and will continue to be our partner also in this process. This is not a contentious process. It's just a process in which we have to be convincing to them that we have all our ducks in a row, so to speak. And so, so you can see that this is the path. And once we have gotten to the IND, then we're really launching into humans. The next phase is phase 1 studies, which are testing safety in humans. And once we clear that, these days with the technologies that we have, we almost always make safe drugs. So by the time a pill goes into a human, it is very often clearing that path because we are very good at designing safe drugs at this point. We have sort of, especially pills. I will not comment on other things like vaccines. That's a contentious point. But for pills, we're pretty good about sort of understanding chemical properties and being able to avoid things that would be toxic to humans. And so by the time we get to the phase 1, I think we have an excellent chance of clearing that hurdle. And then once we clear the phase 1 safety hurdle, we will then be where we all want to be, which is phase 2, testing whether this drug works in a small number of rare disease patients. And so that's the path. We are in lead optimization. We will declare a clinical candidate. We will go into the pre-IND phase. We will file the IND. We will do phase 1, and then we will do phase 2. And while it sounds like a really long path, for most aggressive programs out there, the path from where we are now to going into the clinic, to those phase 1 and phase 2 studies, is usually on the order of 3 years. I want to make clear, especially to our patients, that this is not a promise that I can deliver or anyone can deliver here in 3 years. It's just an average timeline. It may take us longer. Hopefully it would take us shorter, although I can't imagine that being the case. We're doing everything we can, but there are many things that can go wrong. As I described to you, there are many steps in this process. But Drew, this is where we are. So from the publication, we have made progress, but we're on this path that we have to continue to stay on in a very determined fashion in order to finally get to those studies that we need to do.
Right. And I think you've told me before that, even because there are so many potential failure points, you're even still testing other compounds against MUC1 as well, and UMOD.
Yes, we are, both for UMOD and for MUC1, and we call these the backup molecules. It's the molecules that will be kind of at the ready to be brought forward along this path again. If something happens to our clinical candidate, somehow there's a pitfall that is found. Let's say, just to give an example to make it more tangible for folks, let's say one of the requirements is to put the compound in dogs, and see how dogs respond to a particular pill. Let's say, unforeseen, there's a problem. Well, then we have to take that away. We can't give that to humans, right? Because doesn't work for dogs for some reason, or it's toxic or something's going on. So then we have to go back to our backup molecules and search for one that has a different kind of property that avoids the problem issue so that we can bring that forward. This would be an example of how we might be delayed from our kind of optimal 3-year time plan, for example. All we can do is try our best, right? And we're doing everything we can to have the backups lined up, to have, to make wise choices as we go along, and to have all of you as partners in the process so that we can get there. And again, from this community, we need the clinicians and the patients to be aligned with us, to agree that this is the right path to be on, and to be behind the whole process so that we can, when the time comes to actually do the trials, that we have all the kind of organizational pieces in place to make that happen.
Great, thank you. We have another question in the Q&A, and I'm not sure who's best suited to answer this. I've read about CGLT2I and CKD, chronic kidney disease. Might this be useful for slowing down chronic kidney disease in UMOD/MUC1 patients?
Boy, that's an interesting thought. Yeah, we've been thinking about that. So it looks like these drugs, what they do is they increase glucose excretion into the urine. And so they were started as a drug for diabetes, right? Because you get rid of this glucose in the urine. And then surprisingly and happily, they were found to really slow the progression of kidney disease and diabetes. And so then there was a test of just other types of chronic kidney disease, and they were found to slow progression in other types of chronic kidney disease as well. The one thing I think that it's fair to say is we're not really sure what the mechanism of action is for these drugs. But I think it's definitely something that we've been thinking about and we'd potentially like to look into. It's really hard in our disease group, as we said, because of the variable rate of progression of disease. It's really hard for us to figure out. It's different than a lot of other kidney diseases. But yeah, that's something we're very interested in.
Great, thanks so much. We have a raised hand from I believe, Dr. Stavro. Let me see if I can unmute you here. And you can ask your question. I just asked to unmute you if you can, or make your comment. Okay, I'm not sure if, while we're waiting for him, we have another question from, oh, there we go.
Hello.
Hello.
Hello. Hello, Tony.
Hello, great to see you.
How are you?
Very good, thank you.
All right. I wanted just to say how good is your webinar, how I enjoyed it yesterday, how I enjoyed it today. Happy to see you all and hear all the good efforts everyone is doing to achieve what we are trying for. And I'm very optimistic after what I have heard that we have come to what we want to achieve. So hello, Andrea, as well, and Anna, and everybody else. I don't have any special question. I just confirm what Greg said yesterday, that we are working also hard here, trying to go to the control vitamin D trial, and we have collected already 30 patients. And our people are very happy and want to participate, and they try hard to offer what they can. So with all this teamwork, I'm very optimistic for the results. Thank you.
Thank you very much. It's just so great to hear from you and that you're doing well. That's just awesome.
Tony, for those who maybe weren't on yesterday, would you explain who Dr. Stavro is?
Yes, so Dr. Stavro, he actually identified, really, I must say, the first really group of patients with this, ADTKD MUC1. And he wrote an extensive clinical characterization, which I still think is the best clinical characterization we have of the disease. And we really use that as a handbook for all our studies initially. So yeah, it's just great to have him with us.
Thank you very much.
All the way from Cyprus. Thanks so much, Dr. Stavro.
Okay, keep well. Bye-bye.
Another question came in. Dr. Bleyer mentioned that almost all study patients were happy that they were tested. Can you talk more about the findings of this study?
Yes, so we did a quality of life study where we're interested in looking at quality of life of patients with ADTKD. And it turned out, I have to say, you know, as having been an author on this study, I really, really liked it because ADTKD is really just chronic kidney disease. And so when we look at like polycystic kidney disease, if we look at quality of life in polycystic kidney disease, their patients have very large livers, large kidneys, they can have other issues. When we look at it in diabetic kidney disease, there are issues with diabetes and other things. And there's really no other disease, I think, MUC1, the ADTKD MUC1 especially, but UMOD also, is really just chronic kidney disease. And so when we look at the quality of life of patients with these disorders, we're really looking at the quality of life of chronic kidney disease. And so we sent the survey out, our RedCAP survey, to several hundred people. Some of the interesting findings that we had. So first of all, as I said, the findings about the testing, people were in general very happy that they received the testing results, even if they were positive. Another one was, I was, so I'm a very anxious person. And so I was very worried. I was like, well, people with this, with a chronic kidney disease like this are going to have a lot of anxiety. And so maybe we need to target like different things like, centeredness and different approaches. I was thinking maybe we need to have something like that for our patients to help them deal with anxiety. And I was really, really surprised to find out that the level of anxiety was no different in our patients than in the controls. And I talked to one of our patients, and it was very interesting what he had to say. He said that, Tony, I have this disease. Every day I have to take blood pressure medicines for this disease, and I have to take transplant medicines. He said, but at some point I have to go, I'm living my life just like everybody else is. And this isn't the focus of my life. I want to live my life just like everybody wants to live their life. So I thought that that was a really, really insightful answer. And so that was one thing. So not a lot of anxiety, depression, not a lot of depression. Now, as the stages of kidney disease progressed, we asked, like, what symptoms do you get? And Richard, it was really interesting what you said about the fatigue. Yesterday afternoon, I felt really tired, okay? And if I had gone to my doctor and I had said, oh, how do you feel? I'd say, oh, I'm tired. And I don't know how many times as a doctor you hear a patient says, oh, I'm tired. Like, yeah, so I was tired yesterday. And so we're a lot of times this fatigue thing is something. But I was really super impressed at the fatigue level. So patients who are starting in stage 3, but really stage 4 kidney disease, there was a very highly significant difference in the level of fatigue. So now when I see patients, I feel it's really attuned me more to the fatigue of chronic kidney disease. And it's interesting, a lot of patients, and I'd like Richard to give us his take on this, but after they get a transplant, I hear many of my patients say it's like a light bulb went off, turned on. Like I was just so much mentally clearer like 5 minutes after I got the transplant. And so anyhow, so the fatigue is a big thing that we found in our study. Headaches, actually, there were more headaches. But in general, those were the findings. And if anyone wants a copy of the study, if you can email me, and we'll be happy to provide it.
Richard, was that your experience, the light bulb going on?
Let me comment on the first part. Yeah, I was just exhausted. I don't know how I earned a living. I would go downtown to my office, and essentially I was just exhausted all day. I'd come home. I rarely sat at the table with my 3 little boys. Karen accommodated me. And it's not me. I mean, I'm out riding my bike an hour and a half to 2 hours still, multiple times a week now. So when I had that 3-hour operation, I woke up and I was, things, I wouldn't call it a light bulb, but a similar experience of just, I felt electric. I mean, I just was, immediately out of the surgery. And, and then it's a matter of what you do to take care of yourself. I've had 3 siblings, as Drew alluded, that have had transplants, kidney disease, and then transplants. All 3 of them had 2 transplants. And it depends on how you take care of yourself. This was an incredible gift, and I've treated it that way. It was a God-given gift that, And I was going to do everything I could and can still. I don't want to be a fanatic, but I'm not on my soapbox in my normal life telling people, you know, what they ought to eat and all those kind of things. But it just slays me that what people do, and even in our community, you know, after being given one of these gifts. But I've been fortunate with a mindset that I was going to do everything I can to stay healthy. And I've still got some good years left, and I'm really encouraged by Tony and Anna's the progress. I've got several questions, but I want to continue to listen to the other questions of the other patients and families and physicians.
Thanks. Tony, I had kind of a follow-up on the happiness study. So, and I feel like I've heard you talk a little bit about this in the past, but, you know, for instance, there's 21 of us cousins, all 21 have been tested, but some have elected not to find out the results. And so we know that 95% of the people who get the results are okay with that. What if anything, do we know about those who, and I honestly, I do kind of worry about some of my siblings who, like, are they're putting their heads in the sand and just kind of like waiting for this to happen to them. I mean, I don't really get in their face about it, of course, but I do worry about them. Just wondering, how is this going to affect them? Because I think that's exactly what happened to my mom. My mom was, I mean, she's a mother of 7. She had not been to a physician in 4 years when she was diagnosed. And they would have absolutely seen things going up, right? And she wasn't getting those physicals because she was concerned about everybody but herself. And so what about the dynamic of people saying, hey, I really don't want to know, and how do they fare?
Yeah, I think that's you know, we all have the way we deal with this stuff, and for everybody it's different. And so I think that's fine. If people don't want to know, they don't need to know. Now, what they may want to do, so there's another way to find out about the disease that may be a good way, is you just get your creatinine checked once a year. And so, you know, you start out this year, you say your creatinine is totally normal, like way below the normal limit. And then next year it's a little bit higher. And then the next year you get in, your doctor's like, well, I don't think it's anything to worry about, but it's a little bit borderline. And then the next year it's like, well, you know, it's a little bit high. And so what ends up happening is people can kind of find out about it gradually. So that's another way to do it. Most of your relatives are young, they're in their 20s, their risk is really low. I know, you know, and people are just so different, you know, and it's funny because, like, you know, we go to the beach with my family, and you know, my gosh, you know, some people will eat everything. It's no chips, some people, no ice cream, some people, no meat, some people. And so that's tough enough. But when people have a different approach to the disease, like, then it can get, you know, you can be like worried, like, you know. So I would just not worry about it. The one thing that's important that you could do is everybody can get their blood pressure checked. The only thing to slow progression, we don't even know if it slows, but the one thing that I would suggest is people just, you know, just everybody has their blood pressure checked every once in a while. And that's a general thing for everybody. And so, and then, you know, just check your kidney function. I think when they get to 30, then I think it's a good time, but it'd be almost impossible in our culture not to have your kidney function checked by the time between 20 and 30, I think now.
Yeah.
And I just the only comment I want to make is really amplifying what Marie said yesterday in her talk, which is, I think, applicable to PKD as well, where a lot of the same questions have arisen. You know, there are many reasons, all the ones that Tony just listed, to know your status, if you will. But now, with a clinical trial on the horizon, there's another reason, which is that if there is a possible therapy, you probably want to know whether you're eligible, A, to participate in the study. And again, I emphasize that by the time a patient receives this pill, it's going to be safe to take, right? And so, you know, you can, you can be eligible to enroll in a study by knowing your status. And then also the promise of a possible therapy should, you know, we should find the people who are eligible for this therapy. And I think this is a vastly underdiagnosed disease. I think there are many more patients out there, as many of our colleagues mentioned, like Peter Conlon yesterday said that he thinks in Ireland it could be 0.5% of all CKD. Some reports of 1 to 2% in the UK. We probably don't really know the numbers, but they're not negligible, and it's not ultra rare. It's possibly rare, but not ultra rare, I think, is what we're going to find. So, you know, with the promise of a therapy, there's more of an impetus to know whether a person is a carrier of the mutation or not.
Thank you. One of the questions that comes up a lot is, are there other, I mean, you hear all kinds of things, and honestly, especially before we found Tony and Anna, like in our family was like, oh, well, you really shouldn't do this, or if you do this, this will slow things down, or, you know, what other potential treatments are out there that may be beneficial in treating, slowing the progression of UMOD, MUC1? Again, we know that there are other compounds being studied, but are there any other drugs being used, or do we know of any other treatments or ways to slow the progress?
So I'm interested, you know, so one thing I'm interested in is I have a lot of patients who have, you know, stage 3B or higher, so their GFR is less than 45. And so they would be interested in, you know, some type of therapy. So I'm looking at different therapies that are coming available. Now, the SGLT inhibitors, you have to have a GFR in general greater than 45 for those studies. But yeah, I don't want people to think that we're not looking. We're really, that's part of our goal, is to see if we can find other therapies. We don't want, there are several issues with other therapies. So one issue is we don't want to start a therapy that we don't know if it's going to work or not. Like, we won't be able to tell, and then everybody starts using it. Another issue is we don't want to start a therapy with a drug that may be, you know, we don't even think it's dangerous. But we start a therapy, and it turns out we have a bad experience. And then we already have a small number of patients with this condition already. And then if we, you know, people really rely on us, and if we start a therapy with a drug that's, you know, problematic, that could really affect our ability to recruit, because people might not trust us as much. So we are looking for other therapies. We're really interested to see what we could find. I wish we could find some kind of salvage therapy for patients who have a really low GFR. I haven't identified anything yet, but we are looking at that potential. Okay, just say one other thing too, just very quickly. So, and I always tell patients this, and I feel very strongly about this, and just looking at your own family history. So we need to think about things when we're thinking about the disease progression and the disease. We need to think somewhat in 20-year increments. So I'll give you an example. So my cousins have polycystic kidney disease. And so their grandmother never even got on dialysis. So she died without dialysis. Then my uncle, right? So their father, so this was like in the 1970s. So he was on dialysis, and it was it's horrible. He did peritoneal dialysis during the day. He never got put on the transplant list, and he died with, you know, on peritoneal dialysis. So then my cousins were 20 years later, and when they came about, we were like, oh my gosh, it's going to be the same thing as with my uncle. Well, all my cousins, you know, we're like you guys, Richard. There are 45 cousins, and it was just like, okay, who's next to donate, right? And so all of them got preemptively transplanted. There were 3 of them. They've never been on dialysis, but now they've dealt with immunosuppressants. Now think 20 years from now, and there's really exciting work in Boston where they're looking at these, making pigs compatible, pig kidneys compatible. So transplant's going to be super improved over the next 20 years. Dialysis, if you need it, is going to be super improved over the next 20 years. Dean Kamen, as you know, is working in that area. And then there's, and then with our drugs. So I'm really gung-ho for the future for young people. And I always tell all the patients this when we diagnose them. I'm very optimistic, and there are many different areas.
Thanks. That is encouraging. So another question, Wake Forest asks people to participate in this patient registry and then to actually provide labs and specimens every 6 months. So it's pretty involved to do this. Why is it important that families engage in that and then actually do it in over a long period?
It's a really good question. So you can think of these, if we do a clinical trial, we'll have one arm of the trial where we'll have patients that will probably be getting blood work every 3 months, maybe every 6 months. And so what we're doing with our cohort study is we're doing basically the placebo arm of a clinical trial. And so what we're getting from that is we're getting the information, how is kidney function declining over time? And then we're collecting samples, biosamples, so that if we do find a biomarker, we can see how it changes over time. So in essence, we're getting the control group. So it's really incredibly crucial that we get this data and that we get these patients to follow up. And the more that we have, the more that we follow this kidney function over time, then we'll be able to really, what we have to do is make predictions about whether the treatment will work or not. And that will be based on the rates of progression of our patients. And then we have, so that's why it's like a placebo arm of an active trial. It's crucial to our next study. It's absolutely crucial. Anna, do you want to say something to that too?
You covered it. It's absolutely crucial. I agree wholeheartedly. And we are so grateful for patients participating because it just can't be done without the patients, right? No matter how great the ideas are for treatments that we may have, we still, need to do the studies in patients. So it's absolutely critical. And when we get to the FDA, it will become clearly apparent how critical this legwork was that we are doing right now. It's essential. We can't move forward without it. So we are so grateful for the ongoing partnership with patients.
And is there a critical mass of the number of patients you need in that group going into a clinical trial?
Yeah, there is a critical mass, and we'll never reach it. So we'll never have enough. They're never, because the more patients we have, the more likely we'll be able to reach an endpoint. So we either follow a smaller group for longer periods of time, or a larger group for shorter periods of time. Just to give you an idea, like these SGLT inhibitor studies that prove the drugs work, they included in general at least 1,000 patients. So that's, I don't think we'll ever reach 1,000 patients, but we would like, every single person is crucial. And that's a big difference, like between this disease and these other diseases is, my colleague studies diabetes. He could have the first 100,000 people tell him no, and there's still like 20 million people left in the US, right? For us, every person is really super important.
Great. Thank you. I think we have Richard.
So what are we doing to get the word out to the physician community, specifically the nephrology community, the ASN, their trade association? You were published in July of a year ago. Is it going to take actually having a treatment to get their attention? Or is there anything we can do before this 3-year period to get the word out? I've done a little informal survey of 2 or 3 nephrologists, mine and 2 or 3 others in their practice, and they're baffled with some of the patients that they can't answer, why do I have kidney disease? My take is they probably have our kidney disease. But how do we motivate that huge population of nephrologists, the experts, to send us those?
I think, you know, and so that's a big part of our job. And so I'll just give you an example. So there's a gene reviews that the geneticists use. So we're writing the gene reviews for UMOD and MUC1. They asked me to update that this week. That'll take about 2 days to do. Then there's Up to Date. Up to Date is a program that's used by every doctor in the United States and almost all over the world, I would say. Hundreds of millions of users. Our Up to Date site for UMOD and MUC1 got pinged 10,000 times last year. And in the site, we ask people to contact us if they need testing. I'm going to do so I updated that last week. That took 2 days. I'm going to do a review on a related disease that we'll be able to then talk about. I'm doing a webinar for the Kidney Dialysis International Guidelines Association. That will be next week. But the essential, I would say an essential issue, an essential problem is that doctors learn about things in their medical school and in their fellowship. And it's really hard to teach an old dog new tricks. And so the way that doctors will learn, and this is another article that we wrote, we looked at access to care. And basically, there are 3 ways. Either a doctor cares about their patients, primarily care, and contacts us. And we started our work from a family practice doctor. That's how I got everything I've done. It was based on him referring a family. We have, high-priced nephrologists who never consider our diagnosis, right? So we get part of our referrals come directly from patients, which we work really hard to get. Then we have the Up to Date. We have many different sites. We write articles. And now there's a whole thing with genetic testing. And so genetic testing looks like it's going to be used much more of these gene panels in the future. And so these gene panels include UMOD. And so we're getting those. And then there are families, once they get the gene panel and it's negative, they're going to want to know what to do. So I would say I spend about 20% of my time working on outreach.
Great, thank you.
We are getting less families. So I got to say, it used to be we'd get a family that would have 10 members, 15 members. And now we're getting more referrals or like 1 or 2 members. Because if you have 10 or 15 members in a family, they're going to see 10 different doctors and hopefully one of them will refer, right? So we're getting our number of, our family sizes are kind of getting smaller as time goes on.
Marie Hogan had a question or a comment. Marie, are you there?
The discussion is very interesting this morning. It's provocative in that we're all freestyling with these ideas. The idea I have for you is, well, last week I sat in the dialysis unit and filled out the 2728 form, and I think that's a very sobering thing to do. And you look at the kind of level, it's about 20 years to 30 years out of date how the diseases are classified. So Medicare, genetics is transforming renal disease care. So the question is, can we lobby Medicare to change that form so as we can get more granularity of these genetic disorders rather than classify them as end-stage kidney disease due to hypertension? Our nephrologists, of course, aren't very good in many centers at taking a family history, and things are being missed. The other place to look at this, to have a fundamental reboot, is the USRDS. And so the people that are running the USRDS need to be contacted, because the granularity again of cystic and inherited diseases needs a reboot, and the genetic information that's feeding in from the panels, as you said, and individuals who've had testing because it's now affordable needs to get into the databases, and then this will get on the radar of the funding organizations. The this is something the Patient Foundation can lead. Actually, I think the Patient Foundation can get going on this, that you guys want to raise the awareness to this disease, and it needs to be done in a fundamental way with the genetic information tracked by USRDS. That's my suggestion.
Yeah, I think that's
brilliant.
Great idea.
That's a great suggestion. And this is really, it should come from the patients, and it's kind of, you know, going to our elected officials and kind of putting it to them, and going to these organizations that are government run, and trying to fundamentally change how kidney disease is classified and understood, and bring it to the 21st century and bring the element of genetics into how we classify and understand kidney disease. It's completely missing right now. I agree with Marie. We could do far better.
What's happened in PKD world, again, to learn from that, is that the pharma companies, because they want to make, of course, they won't make a drug for you unless they think they can make a profit, and this is the real life situation. So they will go and they will look at the health economics of your disease, and they will write papers about the burden of your disease. And they will go to the EDTA, the Europeans, I'm European, but you know, in Ireland, we didn't have, when I started out, we didn't have a very good registry, but it's much better in Europe now. And again, you guys want to understand how common this disease is, how many people are undiagnosed, and the EDTA registry is the other place that the Patient Foundation and the European members, hopefully, of your foundation can go to EDTA and get this disease categorized in there, since the European groups are doing so much better than we are in terms of genetic testing, since it's provided across your academic centers in Britain and Germany. Our colleagues in Germany and Britain, as two large major populated countries, can go and to the EDTA, and we try to get the genetic diagnosis in there.
Thank you. Thanks so much, Marie. Well, we are winding down on this on our time here for the Q&A. Ask Me Anything. If there's any last comments, we can take a last comment or question, and I think looks like we have one more. So Dr. Bleyer, this will be our last question in this segment, and then we'll move on to Kendrah. Dr. Bleyer mentioned messaging relatives on 23andMe and Ancestry regarding familial kidney disease. Could he review the level of relationship, third, fourth cousins, and preferred method of contact, you know, whether we should get their email address or send them to a website, or what the best way to do that is?
Boy, I tell you, so it's just so, as I was talking about, you know, we're writing a lot of articles, and we have all these up-to-dates that we have to write. I always thought, you know, when we got the computer, we would have like just write one article, right? And then it'd be for everybody. But now it turns out we have to write everything, you know, 20 times instead of once. And so that takes a lot of our time. And then we really want to get into the genealogic stuff. We think that's an area where we could really find a lot more families. And so what that involves, like we have several big families, like we have the deletion inversion family that's in Ireland and in the UK, but also in the US. And so our idea is if family members, if they got on 23, or I don't know about 23andMe, but as much as like Family Tree DNA, all these other family sites, not even the DNA. I'm not interested in the DNA. I'm more interested in the family tree part. And if you got on these websites and you just put, hey, you know, I have inherited kidney disease. If you think you may have it, just contact me or contact Dr. Bleyer. That would be fine. Or you don't even have to say you have it. You could say, I think inherited kidney disease runs in our family. One of our goals was that we would get a family tree site going, and that we'd try to pop in there. We just haven't had time.
That's really interesting, actually. because even if, yeah, like, have you seen anything suspicious in your family regarding people, you know, dying early a few generations ago or whatever?
Yeah.
There's never been an easier time to connect with potential relatives than now.
Like I was thinking with Richard, your family in Belgium, you know, your family comes, or you got you too,
Denmark.
your family comes from, what's that?
Denmark.
Denmark, sorry, Denmark. And so, you know, well, what is there a Danish branch to your family? And so what we're actually doing, we're finally going to be able to fingerprint where the mutation occurs. And when we do that, I think we're going to be able to tell some of these families are related. With the 27 base pair with the UMOD mutations, a lot of them are like fingerprints, and we can tell relationships. And we're hoping to do that with the MKD as well.
Right.
Tony, on that, the older visionary brother that I talked about,
yeah,
has gone over to Denmark, to the Ring, Denmark area, and made a number of contacts, started to pursue that. He was even willing to start knocking on doors of potential relatives to unearth this. There's got to be a way that we can align ourselves with the Ancestries.com and the 23andMe's and use their sophistication. I love the idea of Marie of getting with the regulatory organizations and really define that. Boy, that'd be fantastic. I could never even thought about that. Thank you.
Well, I think we'll wrap up then. Thanks for all the questions. I think we see that, and I see this in our own family and certainly other families that we've met at family days that hopefully we'll be able to convene in person as well as virtually in the future. There are a lot of questions and concerns, and so it's so great to have these answers, and we have so much faith in you as researchers and clinicians, and we're so glad you're on our team, or we're on your team. So with that, I think I'll hand it either back to Tony or Kendrah.
All right. Well, Kendrah, why don't we go ahead and get started? We're very much looking forward. Let me just introduce. So Kendrah has been like a rocket ship for our team. We hired her initially to run our laboratory, but she's also been able to do all of our data management, which has been really, really incredible and helpful. And she basically devised this RedCAP approach. So RedCAP is a system that the NIH has, and Kendrah built the shell that we use, which has been incredible. And so she's going to talk about that today and how we can share it with other groups. So Kendrah, please go ahead.
Thank you. All right, well, thank you all this is an amazing summit these past couple days, and it's so good to see friends that I've made along the years since I've been here since 2012 now, so 8 years. It's amazing. And so many collaborators and people who've sent us DNA. It's good to see all these names and faces. And let me get sharing. Did that share? Are we seeing my screen?
Yep.
Okay, awesome. Let me close that and slideshow. Okay. All right, so today I'm going to talk about how we use RedCAP for ADTKD for our team at Wake Forest. So when I started in 2012, it was in August, so it's been 8 years now. It was Dr. Bleyer and Vicki, and I added 3. And since then, we've added Lauren, who's amazing, and Abby, and Catrice. Everybody is just, it's a wonderful team to work with.
Did we lose Kendrah?
We have a IRB protocol, which is our Institutional Review Board approved protocol to do this. And it's our main IKD study. And so the families that get referred to by Dr. Bleyer all come through this study. and he reviews them, and then he doles those out to our family coordinators, which are Vicki and Lauren and Abby, and now Catrice is coming on as a family coordinator. It's really great. And then they consent the patients and begin all the paperwork and getting family trees and getting in medical records for these individuals. And just, we have a lot of data that we manage with this. Then bringing in samples to begin testing coordination. So I work with that, and Catrice has also been working in the lab a lot. That's how she came in, was for being a lab technician. And then we send out the samples for UMOD or MUC1 testing. And if it's a brand new family and we don't know what they have, we'll send them for UMOD and then MUC1. If it's a positive result, we contact additional family members to do further testing. And then if they're positive and non-ESRD, this is the following group Dr. Bleyer and Dr. Greka have been talking about that are so important in understanding the natural history of it and getting prepared for our FDA trials and application, are these positive individuals with no ESRD that we're following with labs and paired samples every 6 months. And so Lauren has been following MKD patients since 2015. I think we started it that October, so 5 years now. Abby has been following UMOD patients for, I think we started that in 2017. And then Catrice is coming on to help out because it's just growing. It's just more and more individuals, which is great. Then we have the other branch of our workflow, which is working with all of our collaborators. And so these are individuals who either have established IRB protocols and have ADTKD families they've identified, or it's clinicians that have a potential ADTKD patient. And so again, they contact Dr. Bleyer, and I work with them if we are sending batches of samples to us, if we need to establish an MTA. Vicki and I and Catrice work with getting the samples in and making sure they get put in the right queues for testing. We send them for testing for UMOD and MUC1. The results are returned directly to that collaborator. We don't contact their patients for them. They do all that. It's their patients. They contact and return the results as their protocol states. And then if the index cases are positive, they're able to contact the family, recruit additional family members, and send more people to us. And all of these kind of are going into our registry. So it's a lot of information. And if you look at over time in our registry, and this is putting together everybody. So this is Wake Forest enrolled patients and also the collaborators. Our UMOD registry, starting from 2002, when the gene was published, to now, we have 316 families that have been identified and that we know of. We know there's probably more out there, but just in this particular registry, we have 316 families and 838 people who have been genotyped as having a UMOD mutation. And then in the MUC1 registry, that started in 2013 with the publication of the MUC1 mutation as cause for ADTKD. And right now we have 241 families with that in the database and 694 individuals genotyped with a MUC1 mutation. So it's an amazing effort, and it's our effort and it's everybody else's effort coming together to work with us. And so just kind of building on this idea that collaboration is really key to helping these families. And so the MUC1 numbers just keep increasing. So I wouldn't be surprised if they didn't equal the UMOD numbers soon, or if we get it all together. It'd be interesting to see, putting it all together, what our numbers look like worldwide. And that's something I'm getting to later in this presentation. All right. Talking about samples. So these are the samples that we bring in over time. So our cumulative samples, we've processed over 5,000 samples in our little cinder block, no window lab. Went from just a bench to now we actually have our own lab. It's very exciting. And in 2012, we started bringing in collaborator samples. That's when the MUC1 test was first offered by the Broad. And so that's most of what our collaborator samples are DNA samples for us to send to the Broad for MUC1 testing. And so you can see our number of samples have increased over time every year. I included the number of samples we processed for the vitamin D trial because that was additional time and effort that we did. And then you can see in 2020, it's decreased a little bit because of COVID, but it's still, I think, a lot of energy and effort we've done, and hopefully we'll see those numbers increase over the next couple months. So with sample processing, that's changed over time. Currently, this is what our workflow looks like for our biobank. We worked on this a long time to figure out the best method for urine preparation and what we were trying to collect and what we wanted to save back, and at the time, what groups needed. So if we were collaborating with a group looking at a particular biomarker, what did they need, and could we set that aside as we're processing these samples? And so right now, when we send out kits, we ask patients to send back 100 mils of urine, 3 sodium heparin tubes. We use those to spin down and save back plasma, and then an EDTA tube that we use and save that whole blood back for biobank for future DNA isolation. And so we save back some for urinary analysis that needs, we call it unspun just because it's easier to write on all the tubes, but uncentrifuged urine. For those analyses that need uncentrifuged urine, we save some back in O-ring tubes. Then we centrifuge, save some smaller aliquots back of the centrifuged urine, and then larger aliquots. And then the pellet, we don't leave anything to waste. We either save that back for a fax analysis or a urine smear. Sometimes we discard it. Then we have our aliquots we make for plasma and again for the EDTA. And Abby Taylor was great at helping me put this together and make a visual for our lab. And anybody who goes into our lab can see this and put it together. And we have a whole protocol for this if anyone's interested in our SOP for this. Currently in our biobank, we have, just looking at ADTKD genotyped individuals, so UMOD or MUC1 individuals, we have 565 samples with paired labs from 298 individuals. Because of course we have several people that have multiple samples from the longitudinal studies. Of our UMOD individuals, we have 169. And you can see the number of samples. So we have ones that are paired plasma and urine, and then sometimes life happens and your urine's contaminated, so we just have plasma samples on some individuals, and then in some cases we only have urine. But we have quite a bit starting just for this rare disease. It's been really great. We've had to purchase now 2 ultra low freezers for our studies, and it's just growing. And so there's a lot of organization to keep up and track all of this. And so how are we tracking all of this information? So when I first started, and from the initiation, because this Dr. Bleyer's study's been going since 1996, and Vicki joined him in 2003, I believe. Up till 2015, we were using Excel files. And so we had 4 main Excel files. We had a patient Excel file that tracked our individuals and individual samples that came in. They were grouped by family. And this went from column A all the way to column DO. So if you can imagine, it went from A to Z, AA to AZ, BB, or all the way down to DO. It was huge. There's over 2,000 rows. It had all this. It had everything that we needed. It was crucial to the project. It was like the seminal part of what our project was. I also had a separate Excel file for family tracking that Dr. Bleyer kept up with that was index cases. That was column A to AU with 625 families. That was through 2015 with data contact, referral reason, patient referral, was it academic, were they lost to follow-up? If they were, why were they lost to follow-up? Contents of the first email, so we knew that what the family had asked us to begin with, or the physician had asked us to begin with. There's a lot of information there. And then there was the MUC1 and UMOD family registries that were separate, where we were tracking the current health of the person per row, and then also any medical records we had were entered by hand into Excel files. And then when I started in 2012, we started Collaborator sample Excel file. So we had a lot of Excel files that were really, really important. But there's limitations with all of this. At least with the way Wake Forest works with the shared drives, we can only have one person in the file at a time. So you could only one person could update a file at a time. And if you accidentally left it open, you got lots of emails coming around saying, hey, could you get out of this Excel file? I need to put something in. And then if that person was out or on lunch, it was fine for the time, but it could be better. We were very lucky that we didn't have this, but this had happened with other groups I had worked with, where accidentally somebody deleted a page out or a table. And so that data was just kind of lost. You can go back and maybe rescue it with IT, but anything you added to it is lost. So it causes a big problem. For ease of eye strain, because we had so much going on in the spreadsheet, we had rows and columns left as spaces to kind of align yourself. But that makes sorting your data nearly impossible. So you're making lots of copies and trying to delete stuff, and it was just more difficult. And we also had data entered by different team members. And so when you start when you did pull that for analysis, it was harder to analyze, because you can imagine people typing in, gender, you can type in M, you can type male, you can put it lowercase, uppercase. Sometimes there's typos. So there's a lot of cleaning that had to be done when we were using this. And so looking around at ways to make this more efficient, we came upon RedCAP, which was created in 2004 at Vanderbilt for basically this idea of, we want groups to be able to create a safe, secure database to put in their clinical information. And they, at the time in 2004, they wanted to be HIPAA compliant. But since then, governing unions there's more privacy policies. And so RedCAP's adapted to be able to be compliant with these different governing policies for privacy. So it's a web application. Right now, I looked at it just yesterday, there's 138 countries that are part of the RedCAP consortium, over 4,500 institutions. And so when an institution joins the consortium, our team, which is really good, we're not paying to use RedCAP. It's part of what Wake Forest offers for us to have as a tool to manage our data, which is really nice. And there's 1.4 million users now. It's really nice because we can all design and self-build our projects. And so all the projects that we've had, I've gone through and designed it based on what we need. And you can decide, do you want free text to go in? Do you want it to be a button that you click? Do you want it to be a drop down? Do you want it to be a upload? There's a lot of different variables that you can choose from to build it the way that you want it and what's best for your team. What's also awesome is that it allows external collaboration. So you can set up external users that are not at your institution to use. And there's unlimited records and storage available. Other things I like is that we can all access it all at the same time. You also, any changes you make to a field is recorded and timestamped and named. So if something looks odd and you think, human error happens, you know, and we're going back through and we're like, is that creatinine really like 9? We can go through and see who entered it and the date and the time, and we can either go back and ask them like, hey, do you remember putting in this data? Let's go back and look at it. And it's just a better conversation and a better way to track what's going on. Our data is entered in a more consistent fashion. It increases our data integrity. Easily check our documentation of patients. So if somebody calls up, you can go and it's all in one area. What genotyping we've had, all the samples they've had, all the labs that we have, it's all in one place. Reporting out is easy. It just takes a few times of building your own report. You don't have to know any fancy database, SQL or anything like that to be able to make your own reports and search your own queries. And you're also able to change it over time. So as the SNP projects built or biomarkers built, or this spring with COVID, when we started talking to patients and having them send samples again, we were allowed to do that. We had to have screening questions. And so we were able to build those in so that we can track over the time of the pandemic, you know, and show that we met criteria and we met what the IRB was asking us to do with our screening. So again, we use this to track patients and families. We have everything in here. We've got administrative information, medical records, biopsies, every single sample they've had, genetic testing, exploratory variables. We also use it for surveys, and we also used it for the vitamin D clinical trial. And this is just kind of a schematic. If you're better with a picture, then just hear me talk about it. So we have our main IKD project, and then we have separate surveys. We have a health survey that we send out to every single person in our study. We have the quality of life survey that Dr. Bleyer talked about that was published. And then we have a women's health survey that we're just now working with. And we link that back into the IKD project so that our statisticians can go and say, okay, this person filled out the quality of life survey. What does their clinical information look like from this main project? And then separately, we have the clinical trial, and then we have the UMOD mutation registry, which Dr. Bleyer also showed. Let's see. So again, how did we design this? We have every patient's got one record, and then family information is tracked with the index case. In the single event, we have contact information, current health, genotyping, record linking, and then longitudinal, which means we have multiple events for that person, is patient contacts, kit shipments, samples, medical records, anything that you would collect in a serial fashion, excuse me. And so this is just an example of all the different data forms that we currently have in that main big IKD project. We have 1,300 variables, and right now we have over 6,000 records in this project. But I want to note that's not all genotyped individuals. To understand heritability, if for patients that are enrolled, they'll know we ask for family trees. And so the family trees are actually built into RedCAP as well. You'll see there's a little, there's a family tree form. And so that tells us the record ID of their mom and the record ID of their dad and who was the affected parent. And so we're able to group siblings together and do a lot of different analysis. So it's a lot of different types of data, and it's nice to be able to put it all in one place and not have all of it in separate Excel files. And this is just an example of a very active ADTKD patient. So this is looking at their record, and it's huge. And we have this really long line here is all of their medical records. Above it, there's 2 lines, and that's their samples that we've collected. So we've collected 12 samples on this individual. We track when we send kits, so our coordinators track all of this and put that in as documentation so that if somebody calls and maybe they're out of town or working with somebody else, we can go in and say, okay, we saw that your kit was sent here and here's your tracking ID and let's see where it is and all that type of information. Also track consenting, just anything that involves our study and could be documented for that patient, we try to put that into this record. This is just an example of what an actual form looks like. So this is a clinical information, just shows their family diagnosis. So this person's from an MKD family or ADTKD MUC1 family, what their family mutation is, and then we know that they've been genotyped and that they have the disease. And then it's got other information like year of birth, it calculates age, we track gender, race, and it just keeps going down about if they've reached ESRD and things like that. On the other hand, for somebody that's just put in as a family tree member or historic family member, we just have a couple fields and everything else is blank. So not everything is as filled out as this individual. We used this setup also for the clinical trial that Greg mentioned yesterday and Dr. Bleyer talked about today. And it was really great. So I set that up as well. We talked with the coordinators and we talked about Vicki worked together and we made the visit sheets of all the data that we wanted to collect throughout the study. And it was all planned ahead of time. And then we went in and we built the study. And if you look at it for the different visits that we had in the day of every visit, you can see the different procedures that we did. So of course, day one was much more busy and more procedures and things that were collected. And then as, you know, if we needed to review eligibility, treatment was just on one day, how often we collected laboratories, protocol deviations, anything, again, required that we need to know about that patient through a clinical trial, we were able to build that into RedCAP. And with this, I was also able to share this, the data dictionary that RedCAP uses to show us what it looks like. I was able to share that with Greg for the parallel study they're doing in Cyprus, and he's able to take that. He didn't use it, their study was a little different and they have different variables. So he's able to take mine and then adapt it to what he needed. So I was very happy to be able to do that and save, you know, a lot of it's the same. And so we could all use that as a template to start with and then, you know, adapt it to his center and what they actually needed. And that was what the time they had to put into it and not have to do it from the ground up again for this. And this is just an example for like the treatment, what it looked like going in and for the coordinators to put that information in. And then we talked about, Dr. Bleyer showed you the mutational registry. This diagram is also available there. I think I can, yeah. So again, this, if we look at it, it just goes to the survey and fill that out. From our side of it, I just wanted to show you what it kind of looks like on my end. So you can see over here, there's a place for external user request form. I can easily get that for individuals.
Kendrah, that part of your screen is not projecting.
It's not showing. Oh, sorry. I just kept going. Let me see if I can do that. Is that a new share? Thank you for pointing that out. Let me see if I can. Now does it show?
Yes, now we see the RedCAP.
Yeah, great. Thank you. So let me go back and show this. So here for individuals, that are external to Wake Forest, I can easily ask for an external request. And then at the login, there's a place for external collaborators to easily log in. So looking at the mutation registry, for the designer, it's going to make me go into draft mode. this is where you kind of build it in. And so I was able to go in here and make a field so that I could put in this download so that people can access that list of mutations. The mutational diagram, we're able to have it so that people can access that PDF. Here, I just put in basic text fields, but those can easily be made into basically anything you want it to be. We can make it a multiple choice, do like a drop down. You can make it the radio buttons where you just click the little dot. Check boxes, you can make it a yes or no. There's a lot of different things that can be done with it. One thing I wanted to show really quick was how we can use it. And I thought this was a good one because there's no patient information in here at all. This is all de-identified, just about mutations. With reporting, I made this one today just to look at, there's 48 cysteines in UMOD. How many different mutations do we have in this particular registry that involve a cysteine? So if I wanted to look at that, you could go in and it shows all of the different variables that you can pick. So I just kind of chose a lot of them, like the amino acid number and change, and it puts all that in for you. And then here's where you filter it. So I wanted to filter by amino acid change and the cysteine, anything that contains that, and you save it, and it generates the report for you. Okay, and so this shows that in this registry, we have 81 mutations where cysteine has been changed. And so this is a really simple example, but you can see where this can be pretty powerful when you have a large database of patients. So you can go through and see how many MUC1 patients do we have who are ESRD? How many UMOD patients do we have with an EGFR over 30? How many have serum and urine paired with uric acid? So there's a lot of ways you can go through and report this out. And just a little bit of playing with the reporting, and obviously if there's any question, your institution should have a RedCAP administrator that can help along with it. But it's been just invaluable, I think, with allowing us to be way more efficient and trying to create data sets and manage all of this data that we have. So I'm going to go back to this, and I think I just killed my screen share again. Let's go. Let's go from current slide. Is that showing where we were again? Is that showing correctly? Okay. So again, just a quick review of how we report in that. We have hundreds that we all use, hundreds of different reports just in the main database of how we're using RedCAP and reporting out from it. Going into the different surveys, again, we had the quality of life survey that we put together, built that into a RedCAP project. We had 286 individuals complete that. We matched it in their IKD with their record there. And this is just, again, an example of what it looked like as I was building this together. And currently we have a women's health survey. This is a sub-study of the, off of the same IKD protocol. And it was approved in June. So we worked together looking at literature of what was asked, what patients have been asking, and also working with the biostatisticians about what they want when they're trying to analyze it. So how could we build this to be better for analysis and trying to answer this question? And so we built this, and there's multiple, I built a survey queue, so it's a little different. We were able to build into this one a consent form, so they consent into the survey directly. And then it builds a survey queue based on the number of pregnancies that they have. And so, you know, you may have somebody taking the survey that has not had a pregnancy, and you may have another person taking it that have had, you know, has had 8 pregnancies. And so how we had to think about how are you going to show that, because either it's not enough forms or that's a lot of forms for people to go through that haven't had, you know, 8 or 10 pregnancies. So we were able to, I was able to code it here in the survey queue so that if they answer one question for the number of pregnancies, it codes out the exact number of pregnancy forms that they needed to fill out. And so it's really nice that you're able to kind of take your project and make it, create it the way that you need it and to meet patient needs, and make it as friendly as possible for patients, and not overwhelm them, and make it user friendly. So I think we've gotten pretty good feedback from the 140 individuals who've filled it out so far. And we always go through if people have questions and help them out or see what we can do to make it better. So that's ongoing. We had a publication about the registry itself, looking at the outcomes of patient referral for diagnosis versus academic and non-academic healthcare providers. And so with this, we were able to use RedCAP to look at our index cases, patient referrals, what was the progress of the family, where they declined or lost a follow-up. So we were able to make this figure 1, which is a really nice flow chart of how did we get from 828 referrals down to 98 UMOD families and 65 MUC1 families, and go from there. So I think this publication was really great in showing our registry and how patients are referring themselves and how that looks with academic and non-academic providers with the final diagnosis, but also the power of what we have here with the way we've designed our RedCAP registry. We've had a couple, so here's 2 examples of collaborative papers with the MUC1 registry. One was pre-RedCAP in 2014, where we had 24 families and 95 MUC1 individuals, versus another one where we were looking at identifying novel MUC1 mutations. And so pre-RedCAP, we had to pull from our different Excel sheets and put that together. And it was doable for 24 families and 95 people. But now that we're looking at hundreds of families and, you know, 900 people, it's nice it's nice to be able to pull it directly from, be able to query and report that out directly and not have to kind of patchwork it all together from different Excel files. The nice thing with the the non-invasive immunohistochemical diagnosis paper is that we were able to go through query, see what biopsies are available, identify families. So we were able to go through, see what MUC1 people we had, see what families looked like they had MUC1 but didn't have the C insertion, and identify those to contact and get samples. And we were able to build new forms for this and make it all very, searchable and easier to manage. And then again, other papers that we've talked about over the past couple of days, the paper with Eric looking at combining our registry with their registry for this huge ADTKD cohort. We were able to share our data set with him for this publication, which was really great to do. And it's an amazing paper. For the UMOD, the SNP paper, the predictors of age and ESKD, we started that as a SNP paper. And so we were able to create the SNP data form. And then as collaborators were sending in information from Excel, we put that directly into RedCAP. And then Martina's paper of, well, our collaborative paper where Martina was the first author about RIN was another wonderful collaborative paper where we were able to report out our RIN patients, and then collaborators sent their clinical data to us by Excel. And we put all of that together for the clinical aspects of this paper. And it's another wonderful showing what the power of collaboration is for this. So while it's been awesome and we've been able to put out some great papers, there are limitations to just our registry. Right now, we only are having Wake Forest research staff enter data, and we have so many fields. Like there's a lot and they're important to us, but they're Wake Forest specific for our coordinators and our projects. You know, when working with the larger community, you know, we're seeing, you know, are we all collecting the same data? Is it in the same format? How can we bring this together? And currently, again, we only have longitudinal data for our families, the Wake Forest families in the registry with a well-defined natural history. But we would like to expand that because every patient's important, every family is important, and it'd be great to, the more we have, the better it's going to be, right? And looking at that, also we have with our surveys, you know, Dr. Bleyer talked about that, touched on that a little bit with the PKD. It would be great to bring in more people interested in the quality of life and women's health also with our surveys. So we'd be happy to share those surveys and our sub-study language and things like that with groups that are interested. So looking forward into this, how could we make this better? We want to make sure we're collecting the same data with the same format. If we're looking at biobanking, we want to make sure our samples are being collected by in the same way, the same protocols. It'd be great for collaborators to be able to access their patients directly to update and have ownership in that and feel part of it. And that we all together feel unified on the goals to help these families. And with that, we can get a better understanding of the natural history and the prevalence and have a better defined population to present to the FDA for future clinical trials. So how can we do this? I just kind of came up with a couple goals off the top of my head as I've been working with Catherine and a couple other collaborators to get this started, kind of like what can we do to get to this? So we want to create a collaborative ADTKD network, a central methodology for data collection, a central data repository would be ideal. And through this, we can collaborate on projects with data and samples for biomarkers. And again, to better understand the natural history of ADTKD and utilize this for clinical trial application. So right now, this is just amazing with the summit and reaching goal 1 and starting there, right? Because we have collaborations that exist, but we can always bring more in and bring more people in together and have everybody play off of the strengths of their team. I know that there's been the collaborator breakfast at ASN in the past, and then in 2020, there's initiation of a collaborator quarterly call, and then our first annual ADTKD summit. So hopefully it'll just grow from here. I think that'd be great. A central methodology for data collection. I'm going to get to the end and then I'm going to show this since I don't, so I won't have to keep flipping back and forth with my weird screen sharing. But I do have a prototype of a RedCAP project I can kind of show you. The basic setup is just having coordinating information. One idea is having a family identifier, but thinking about heritability, you know, things not to be decided today, but, you know, in the future, as we're talking about this, is do we need, you know, what would we need to include? Do we need to include familial relationships and things like that? Obviously, we need to know your PI, research team information, patient information, just basic demographics, current kidney function, and then are you biobanking at your facility, and then longitudinal information. And so in order to create the central data repository, we have to think about this and do this the right way. So we need to identify our stakeholders and set a foundation. And so when you think about it, who are our stakeholders? So we have our patients and our researchers, but we kind of have governing groups over us that we have to also make sure we're meeting. And so one of those are governing union policies like GDPR, HIPAA, that are so important in protecting our patient information and privacy. And so we need to make sure that we're meeting those requirements in the formation of a registry. We also want to make sure we're meeting research standards like our institutional review boards and ethics committees for GCP, and which is protecting our patients' rights to autonomous consent and safety with the with the writing of our protocols in ICF. Our patients, Drew and Richard and all of our patients are just so awesome and can speak to their, what they're holding with this more so than me, but I know they're looking, so many are looking for answers to their family disease. They want to know what the future holds. They want to know there's research updates and treatments that are giving hope for themselves and their family, and that each family and each patient just contributes so much to our research. But we want that those governing bodies and the research is also protecting them for many reasons. And one thing we're also looking at starting up with our group is a patient advisory board. So that's something we'll talk about as that starts getting set up more and more. And then of course, there are researchers and physicians that work with the patients. I know some of you have been following families for generations and looking to find and setting up genetic testing. And it was awesome yesterday to hear how different clinics and countries are setting up genetic testing and tracking, not tracking necessarily, but tabulating what's, kidney disease and genetic kidney disease in their country. We're designing projects and writing grants to help patients. There's so much innovation going on. It's awesome. And then collaboration. So there's a lot of stakeholders in setting up the central registry. And so with that in mind, when we're setting this up, we need to figure out a way to get the data transferred into a registry, secure a place for the data registry, and then we have to know how we're using that data. And so these are all things that we're working through as time goes on. The main thing right now is setting it up. Researchers would need to have a protocol to identify the families and then amend their protocol to share that de-identified data into a registry. And that would include signing like a data sharing agreement to allow the transfer of data in. Then once we get there, our current plan would be to use RedCAP, and it'd be maintained by Wake Forest, but everybody would be an external collaborator and equal part in putting the data in together and ownership of the registry. And we would all be using the same templates, and the idea would be you could either enter data directly into it, or you could have something where you're using the same variable names and you could import it in easily. And so again, this would give group ownership of the data, and it could expand as projects expand as a whole group together. How to use the data, this again would be future talks, but just something to think about. Once we put all of this together, everybody would have access to data from other groups. And so we need to think about, how to use that. Would we need to have a joint data access committee? That was something that was brought up by our regulatory affairs individual, that, each group has a vote, and there's just different things with that. Something to talk about in the future. And so where are we with this? So I have a shell built in RedCAP, working on how to bring the data in and the legal agreements that would need to be in place. And right now we're working with this great group of researchers who are kind of paving the way with their institutions and have been on a couple calls with Catherine and I. and they've been invaluable players with this, and we're hoping to have something more to present with this soon with where we are. And so we'd also like to know if other groups are interested in joining this registry, and how many families do you have, and ideas for a collaborative project. And then just a summary of what we're doing, where we are and what we're doing is to continue working towards this central ADTKD data registry. I'm happy to share any RedCAP data dictionaries we have and provide further help with setup, training on how to put the data dictionary in and get it set up. I can write SOPs for data entry. I can do training better for reports, because I just showed that like in 2 minutes. It's really easy, but I know that, I'm happy to do, one-on-one training or do a more in-depth training for that. And then again, this is working towards more collaboration and better understanding and help for ADTKD families. And then these are some of our collaborating institutions. It's not all of them. And if I've left anybody out and you're on here, I did not mean to. And we're just so thankful for all the groups that we have been working with and hope to work with new groups in the future. And I would like to just show the basic registry that I kind of started. So it kicked me out, which is good, because then it can show what it, oh, I think it can, sorry. Let me do this new share. There, okay. So if you went to the Wake Forest RedCAP page as a non-Wake Health user, you would go in here and type in your email, and if you're registered, it'll take you right to the projects that you have access to. So it's very easy. Let's see. So I just built a real quick shell of it. And I built this based on what would be, when we were thinking about this and trying to talk to IT security and regulatory affairs and all these groups that are really important and want to make sure that we're doing things correctly, what was the bare minimum of data that we want to know? Like if they said, okay, but you can only do this, minimum in a registry to start out with, what is that? And so that's kind of where this is. So it can be expanded on here. So if we're adding, I'm just going to show how it would look. Right now, there's just the 3 forms: coordinating information, basic patient information, and medical records. I only built out 5 as kind of a prototype. And so if a group was coming in and you had a new patient with ADTKD that you wanted to enter, you would put a new record in and you go to coordinating information and you give your patient identifier, however you want to link it to your group. I don't want, just like not a number that makes sense to you. A family information, like family 12. PI, we will add to this. I have this coded in institutions. I was planning on making that a drop down also, so that would be faster for people. Country, email, I can add in extra spaces for, a main project coordinator or a postdoc or any other people we would need to contact for the team that might be good. So I'm going to save that, and it kind of kicked me out. Then into the patient information for this person, the year they were born, so that we're not intruding on dates. If we know gender, if we know race, ethnicity, and then genetic information, what do they have? They have UMOD. And so then I have a list of UMOD mutations. We can make a drop down for that. For that, there's space for weight and height, history of smoking, do they have a history of protein or blood in the urine, of hyperuricemia? Do they have a history of gout? If yes, you know, what age did they start? Are they taking any gout medications? And then with this, if they answer, have they reached end-stage kidney disease? If no, then it drops down to ask, what's your current function? So you could put in like today's date and their value was, you know, 1.5, because we're in the US, it's milligrams per deciliter. So I put in the units so that we can easily track who's using what units, and so that it makes sense. Date of their last serum uric acid, and then biobank specimens. Right now we just have whether, you know, we can just let other groups know that, yes, we have DNA, urine, plasma, saved back on this person. And then if we have serial labs, this is just kind of the bare bones of what we would be collecting from serial labs with the date of visit, so we would know how old they were at the time and can kind of see their progression in there. But that's kind of the idea for this. And again, there's a data dictionary that we can download and share. There's ways to import patients directly if you have it set up by the exact variable names that are in there. There's a lot of ways that we can use it. I don't want to, I'm kind of hitting my time anyway, but you know, there's a lot more that I can show how we can all use this together. But I hope that this is a good start and something that the group will be interested in and would be, I think it'd be useful for moving forward with understanding where you are with prevalence and better understanding the natural history of disease. So
excellent, Kendrah. Very good, very good.
So if there's any questions, or I can.
Can I just address one question that I think would be important for the whole group to hear and know about? So can you speak a little bit to the fact that how the data are federated, so that the person who, maybe you mentioned this and I missed it, but the person who contributes data, let's say I'm sitting in, you know, in Greece and I want to contribute, you know, my 20 patients, you know. Yes, I contribute to this general pool of de-identified data, which is for the benefit of the whole project. But what if I want to also like compare my patients to other patients? What can I do sitting in Greece, for example, with my data? Can you speak to that a little bit?
Right. So I guess what you're asking is like, could you report out and see how your group was looking towards the other groups?
Maybe, or, you know, what can I maintain the integrity of my data while I'm also, you know, contributing to the pool? Right. You know, how does it all work? Or even comparing to the rest of the pool.
Right. So I think that's some of the questions that we're trying to get answered with working with. So we're trying to first make sure they were reaching, you know, meeting policy and protection and privacy with bringing the data in. And so then I think the question of how to use it comes with that third prong. Like we bring it in, we put it in a safe space, and then how are we going to use that, and how are people going to agree to use it?
So I think, can I just say, so the ideal would be that if you're sitting in Greece and you have 20 patients that you're putting in, you would have the private data, their names and everything would stick with you. And no one else would have that data. Then the general data of those 20 patients would be available to whoever is designated in the registry to use those 20 patients. You would always have the designation to use that data and write reports on your 20 patients. Then the question would be, how do we share the data? So for example, say, say you contributed like 50 patients and you're like, well, I'd like to look at the whole database and write an article. That would be obviously very reasonable. We're more interested in sharing the data. and then, but it would have to be something we'd all, in the end, we might have to formalize a little bit more. So for example, someone wants to use a database, they put one person in the database and they're like, wow, I want to have access to everything. That might be, so that would be something we could decide on. But I think for right now, it's not, it wouldn't be that big, it wouldn't be an issue, but it may be something actually we should discuss early on before it is an issue.
Yeah.
Well, from my perspective, what I wanted to say is that I think this is an opportunity to really speak to the fact that, you know, we should agree to do this collaboratively as a team. And so we all publish together as a team. Whether you contribute 1 patient or 50 patients, you're part of the team. And so, you know, we all kind of work together. And I think that that's one of the sort of foundational understandings that I'm hoping we can, you know, come to here. You know, if we all contribute data, we all share in the publications as well. And I think that makes perfect sense for any consortium. You know, that's how it's been managed in the field of genetics for, you know, for years, right? And so
yeah, we're totally in agreement
here to the extent that our data are safe and are appropriate to be shared based on like the European legal framework that has recently changed, and you know, I don't know, data coming from Singapore or from Australia or from wherever they're coming, you know, compliant with the local laws, of course, but with the idea that if we're using them in the consortium, you know, everybody gets to, you know, publish together. I think that's,
yeah, I mean, I don't think that's an issue, right? If you look at all the manuscripts we've written, I mean, we've had, yeah, so that, yeah, we're totally in agreement with that.
Yeah, and I think with part of it also is when somebody joins, and the idea with I think I kind of skipped over it a little too fast. When somebody joins, they'll have to update their protocol and ICF, and that would go for us also here at Wake Forest. And part of that is that we're agreeing to join together, and we could even put into that language and into some of the beginning part to align our project together of putting that data into that central repository, how it's going to be used. And so if you agree to join this group and you agree to share your data, then if you're publishing from this data, you agree to include everybody and that we're all part of this consortium. I think that that's something that could be
exactly
my idea. Yeah.
And so if an investigator sitting, again, I'll give the example of Greece, has an idea for analyzing the data in a particular way, you know, the gift of contributing to the cohort means that you can also ask your question. Let's say I want to know if, you know, the total protein of a patient with UMOD is different from whatever, MKD patient. And I have this question, right? And so, you know, and then I end up finding something, the whole consortium publishes, I led that particular project with the benefit of the whole data, right? And so I think this is how you can recruit collaborators by, I think all of us here, everybody wants to share, everybody wants to get something out as well, right? And you know, we all are driven by the same sort of both noble motivations of helping our patients and also driven by the need for academic publishing. And so I think the way to drive collaboration is to sort of make it possible for anyone who, you know, wants to participate to also be able to get something out of the consortium in terms of, you know, asking questions they have.
There's one aspect that we need to discuss too, that, so right now, you know, there are all these rules and laws in different countries about sharing data. So in our group too, you know, we're not going to be able to reach out and, like, for example, you know, reach out to the government of Greece and ask if it's okay to do the study. So we're not going to be able to reach out to the United Kingdom and say, hey, you know, is it okay if, you know, Dr. Sayer, if he starts a registry? So that's just beyond what we're able to do right now. Now, I think
I don't believe that's necessary, right? Because every institution will have their own local rules by which they collect their data, and they will know how they can share it or not based on their own framework. Like the GDPR right? We'll provide the framework for the European countries, and they will know what they can share or not,
Yeah,
right?
that's fine with us. Though we tried to start a registry during COVID, and we were told we had to spearhead the registry with the UK. We said, well, we'll just let the researcher in the UK go ahead and do this. And they said, no, your group is the primary, so you have to do it. So that could be a problem. Now, however, there's another way too that we're offering to do this, which I think is a good intermediate step. And that is that we give everybody the shell of RedCAP. So, for example, if you're in Cyprus and you don't know about all the rules and the timing, and they have certain rules that they don't want to allow collaboration and ongoing live collaboration. We send you the shell. You put all your patients into RedCAP, and then a year or two from now, you say, "Hey, I'd like to collaborate on this project." And we put it through some IRB together in Cyprus or something, or Greece. And then we can merge the databases very easily. So one idea is that if we just send people our RedCAP database, and they may be like, well, Tony, I like the idea, we like the idea of having the database, but because of laws and because of the way our university works, I'm not that red hot about just adding patients into the registry all the time. So what we can do is just give you the database. People can take the database. Which is like so there's like, it's like a computer program, and it's like then just say like Microsoft Excel, right? RedCAP is like Microsoft Excel. It's analogous, but it's free. So everybody can download RedCAP onto their computer. Now, if you want an Excel spreadsheet that's already set up, that would be like our RedCAP program. So we can give you our program, our database, and we can give it to our friend in Greece. And he can take that program and he can put in whatever data he wants and have that as his own separate program. Then over time, he says, this actually works out pretty well. I'd like to do this with the guys at, Wake Forest. He can do that. The data will already be in, so we can merge. Or he may say, well, I still want to keep my stuff separate, but 2 years down the line, we do a project on maternal health. And he says, I'd like to be involved in that, and I can merge. Our biggest issue, Kendrah brought up the Renin one, and we tried to do Renin through an Excel spreadsheet, or we did do it through an Excel spreadsheet, and we'll never do it through that way again, because people just, they were just putting stuff in the spreadsheet that was unintelligible, and we had to make a lot of changes. So anyhow, so those are the options. So if any of you guys just want the RedCAP spreadsheet to look at, to mess around in it, see if you like it or not, we can just give it to you and we can give you training.
That's perfect. Drew, are we taking a break?
Wait, there's a question I see from Kathleen. Let's see here. Hold on, I am very happy to collaborate in this consortium and have a more in-depth conversation in the next couple of weeks. So I'm glad you are working with the RedCAP available in our institution. GDPR will be a challenge, stricter than your registration. We definitely need to have a data transfer agreement in GDPR. You have a controller and a data processor. You would then be the controller. Tony, the merge you suggest will give you the same hurdles afterwards. Yes, I understand that we still would have to go over these hurdles later. But it may, I don't know, I would prefer to go over the hurdles later in some ways after people have started using it, because I think these hurdles could be pretty intense. And I would not like to go through like a whole year of going through these hurdles and then, people are like, turns out the registry wasn't as good as I liked. So that's.
Yeah, I mean, it sounds to me, and maybe we're barreling through our break and kind of moving on to the next session, and maybe that will be a natural way for us to close. Like, what are our next steps, essentially?
I just wanted to say one thing about some of with the GDPR and the controller. If people who are interested in starting this now, if you will email me, I'm going to type my email into everybody, if you don't already have it, to make sure you have it. But at Wake Forest, I've been kind of talking with the group to make sure we're setting, again, we want to set this up correctly. And our legal group and IT group and regulatory affairs, they're looking into this, and they would really like to talk to individuals who have experience with this. So talking to people from the EU who have worked with GDPR, maybe we could set up some kind of call soon with individuals interested, ourselves, and get the legal person from Wake Forest into it so they can start understanding a little better about how we can start meeting those hurdles.
Yeah, I think that's what I was going to say, and I know that Catherine Blakesley and the folks at the Broad have been very seriously involved in this as well, because the Broad have done this many times over to share genetic information with consortia in Europe. Obviously, we aggregate massive amounts of exome and whole genome sequencing at the Broad. And so we have a framework for this. We have done this before, and it's highly doable. It's just an issue of, getting everything, organized. And so Catherine Blakesley and you, Kendrah, have been discussing this. And I think, to me, it seems from our discussions, this is like one natural next action item from this meeting, this summit, as a next step. That for those interested in joining our consortium, for example, Kathleen, but also others, anyone out there who is listening now or who has colleagues who they think would be interested, I think it's right that, if you email Kendrah, and maybe you could put it in the, put your email in the chat, Kendrah, then, we can organize, mostly you can organize a meeting, we is the royal we, but, to really iron out these specific details, which are really important. And maybe the meeting is separate. I know you also have had a super user meeting, with folks from Australia and other parts in Europe. Maybe there needs to be a separate meeting for our EU colleagues who have, at the moment, a very stringent legal framework with the GDPR. And maybe it's separate for colleagues in the United States and even other parts of the world, And so, it is a little bit of legwork, but our ultimate goal is to aggregate as many patients as we possibly can. That's going to be our strength when we get to the regulatory agencies, both the EMA, the European Medicines Agency, as well as the FDA here in the United States, and other regulatory agencies also in Japan, for example, in Asia. So I think that we need to have as many patients as possible. The natural history of the disease is going to be critical for us to be able to convince them of what we're trying to do. And so to me, going through the pain of, organizing ourselves now will be to the benefit of this community later. And so again, since you're willing to do this, Kendrah, as a next step, to email you and to organize such a meeting, and Catherine can help, I know, because she's been also helpful and involved.
Oh, yeah.
I'm volunteering you, Catherine, but
well, it would be great if perhaps if the Broad, some of the legal group, like Emily, that we talked with before, could also join and kind of live there.
Definitely.
That's what I'm thinking, because if we've solved this problem once before, certainly it can be applied here again, now from the Wake Forest side, but we're both in the United States, so it should be facing toward Europe. It should be very similar paths, and so we can reproduce that work. And yeah, I just want to make sure that everyone who's listening today knows that they're, very invited to be part of this registry. We're going to try to make it work for everyone, most importantly for our patients, but that everybody's academic mission can also be served by publishing, contributing, and publishing through this framework, if we set it up right. And, to Tony's point, he's been, spearheading this for so long. There are so many established collaborations, thanks to your amazing kind of pioneering work, Tony, that now this is just a couple of new legal hurdles, but, I think that we can overcome them.
Yeah, we're very interested to do so. Yeah.
Kathleen is saying the legal department is crucial. Yeah, I agree. I think definitely the legal department is crucial. That's what I understood as well. And these guys have been thinking about this for some time now. So, yeah, the folks at the Broad have done this many times over. We've done it for the Nomad platform. We've done it for ClinGen. We've done it for the Human Cell Atlas. And so we know this data sharing business is paperwork and legal departments, but at the end it can be done, you know. And so yeah, I'm very hopeful for that. And so then I guess the next question is about next steps.
And
it sounds like, sorry, go ahead.
Before you start that, can I just tee up kind of how we're going to technically do this in this last segment?
Yes, please.
So thus far, a lot of the attendees have been kind of just watching and maybe having a few drills. We're going to actually make everyone on the call, it's almost 50 people, panelists for this last part, so we can have a little bit more interaction. It's important for people to stay muted and still use the hand raise feature. So that otherwise, you know, we've all been on Zoom calls where there's too many people or trying to talk over each other. So, but we wanted to make this last segment a little bit more interactive. So, so you'll get those, we'll start kind of upgrading people to panelists here, and then just keep that in mind for this last segment, and we should be great. But yeah, take it away, Anna.
Well, thank you, Drew. Yeah, I mean, all I want to say is it sounds like we have one action item on the list already, and it's centered around Kendrah, with help from Catherine and the legal departments and collaborators. So that's one action item. And then I just wanted to see, you know, what people thought as additional action items. One area that I see, and we have discussed in our quarterly calls, is around the biomarker piece of this project. And I was wondering if Marie had any additional comments on that from past experience with PKD, and also maybe, you know, we could have as a next step action item, also a kind of a working group or some kind of subgroup that really focuses on the biomarker questions. So
we will follow up with you on the biomarker with some imaging analysis that we're doing, and we would be happy to participate in that. If we were to look back at the PKD experience, I think that might be an area for NIH grant writing, that we got a consortium together. I think what you need to do is get little working groups going and get various people from Europe and Eurasia and the people interested, and get little working groups going. And then a thing I've learned from the Neptune consortium is that you can have people that are active in your protocols, you know, like you talked about your registry and all of that, but you can have kind of mirror sites that are doing exactly the same thing, but they're not in your protocol, but they're collecting exactly the same information. And then you can eventually merge the de-identified data. So if you decide how many how often, like just simple things like creatinine, if we all collect creatinine and kidney function once a year, then we can merge the data for you eventually from all the separate centers, and that would be very powerful.
yeah, that's terrific. Okay, so it sounds like one working group is definitely centered around Kendrah and the registry and the organization of that. And as you say, maybe there are mirror registries just using the same entry criteria for RedCAP, but they're not merged until a later time. I think to overcome some legal hurdles, that could be. Yes, Tony.
So Catherine, can you help us with that?
Catherine Blakesley.
Absolutely.
All right, so you'll be able to help with that, with the coordination. All right, well, very good. Just want to make sure.
Yeah, I think we can expand our super user group and, you know, kind of workshop these legal hurdles together, because we can all learn from one another.
All right, okay, good. That's something we don't have any expertise in, and it sounds like the Broad has super expertise. So we would have to rely on you guys really to help us with that. That would make the most sense.
Yeah, absolutely.
That's perfect. So we already have that working group going, and, you know, people can email Kendrah and then she can connect them with Catherine, and we'll
yeah, I mean, I think even Catherine might want to spearhead this international agreement thing, because that will be something that she has the most experience and the people at the Broad do. So that might work out.
Sure.
Yeah, be very good. Great.
Catherine, why don't you put your email in the chat as well, so that everyone knows to contact you and Kendrah in order to make this happen. So that's one working group: registry, legal, data transfer agreements, all the intricacies of making the data sharing somehow work, right? That's one aspect, registry. Okay, and then we need, as Marie was saying, kind of a biomarker working group. I know that in the past, Michael was interested in spearheading some of those efforts. Any thoughts there, Michael or Wiesner, or anyone else, really?
Unmute.
Oh, we need to unmute you. How?
You need to unmute, Michael. There we go.
Yeah, we're not really working on biomarkers. So can't help there.
Maybe not the optimal place to go. Anyone else? I mean, Marie, you have a long-standing interest in this area. How shall we do this? We certainly have an effort going on at the Broad that has more to do with detection of MUC1 in the urine at the moment. And then you have some imaging. Maybe this is the right place to start, right? Oh, you're muted too. Oops.
Oh, can you hear me now? Yeah, the imaging thing, we can set up a subsequent meeting. I asked Kendrah to send me, we get all our list of patients more organized with you, but the imaging is one part of it. Then the biofluid biomarker, again, Neptune, we worked on a protocol for the urine, and then, you know, the samples are archived. So again, separate centers could be saving urine once a year and a blood sample once a year. One thing I've just been very interested in with our biobanking here at Mayo that could ease up the difficulty with getting a DNA sample would be our biobank have really fast-tracked. They're on version 2 of a saliva DNA. And so you can mail out the kit to the patient directly, and you can get the saliva back. And that could be something you could implement across various continents for local collection. It would ease and rapidly build over the next few years your DNA biobank. Because DNA really is the ultimate biomarker at the moment of your disease. So there's the imaging, the DNA, and the urine. Yeah, that's great. You have a very nice protocol for storage. But again, to put that out there, to promote that and get the patient, maybe get the patient foundation to help promote that with the various, the patient foundation, you know, the patient chapters are really powerful. I was just looking on the PKD Foundation now, you know, there's, I don't know, 50, 60 different chapters, and they all have meetings and patient meetings. And so empowerment, you know, patient empowerment is very, very important. The voice of the patient is very important. Some of our patients have been getting into our nephrology journals now and discussing the importance of genetic testing. The patient voice is very important. So again, the Patient Foundation are on here to urge you to get out there and say, this registry is here. Can you send in a blood or saliva sample? You know, how's that done? Maybe that direct patient contact.
That sounds good. I mean, sounds like a couple of streams there. So maybe, Catherine, we'll make it also another action item to organize a meeting between us at Broad and Marie, and then anyone who is interested in contributing to biomarker work can also email Catherine Blakesley, who just put her email in the chat, to participate in that. Greg, by definition, is a participant of that together with our team. And so, you know, we continue the collaboration with Cyprus on the biomarker work, but maybe expand further and then see if there's other colleagues who want to participate in that as well. Again, yes, it includes genetic criteria, so genetic diagnosis in order to enter into a study. It could be urine, as you mentioned, and also perhaps there is an angle that involves imaging that we should explore. So maybe we'll have a separate working group on that. And so what I'm envisioning is that I want to propose to this group is, rather than having quarterly calls with the entire group, maybe we should, for the next little bit, do subgroup calls, working group calls, to make progress and then report back to the larger group at like the half-year point or something to that effect, and then have another summit a year from now and take stock of what the working groups accomplished. So registry working group, biomarker working group, and then it seems to me that we have an ask of our patients, right? Drew and Richard, I think reaching out to other, I'm not sure who else on this call is from the patient perspective, but your voices are going to be really important.
I know that Drew had to hop off, but one of the things I was thinking about, and Anna, you'll probably remember this from the Rare Genomes Project, is we kind of got a family advisory group together. We had sort of like a constitution of what this group was like spearheading to do to really be our partners in the research. So we could do something very similar to that for this patient.
Could we just do an exercise of anyone who is a patient or a family member here, raise their hand so we can count? Can you see, Catherine? You're the host, so you can count. Raise hands, anyone? Maybe people are.
I'm seeing one, hold on. One, scrolling. I'm not gonna single the, well, it seems like everybody.
No, it's okay.
I'm trying to. Trying to find that cue. Add me to it.
So it sounds like we have a handful of patients, but you know, Richard, you're really good about organizing people. So we'll have to ask you to kind of beyond the Nelson family, try to reach out to other families and sort of see. I know that when we had the last family meeting, there were several other families who wanted to be involved.
Right.
We've had families at our DC meeting, the ASN meeting, as well as the Boston meeting. It'll be good to organize yourselves and maybe advocate, maybe at the level of the AAKP, the American Association of Kidney Patients. I know you already know Paul Conway very well, and there's been some movement there. And then I think for European colleagues or colleagues other places, we need to also connect Richard to patients in Europe and have them organize amongst themselves, I think.
Not to single this person out, but Michael, I know that you had some patients in Germany that you were hoping to invite to this call. Maybe we could also kind of wrangle them in for this group.
Yeah, we would welcome that. I think that Wake Forest, Tony and Kendrah would have the bulk of that group. We would love to work closely with them to get that message out, and because we don't have the specifics there. And I know there's some sensitivity with regulatory and Catherine, help us kind of, and Kendrah, help us kind of work through that so that we can bring that voice together, because it is powerful. We've been working with other organizations in Washington, D.C. For example, in the last 2 weeks, I've had 4 calls with members of Congress advocating upon, the broader rare disease area. And I've had, it works. It's surprising and it's powerful. Like Martina said yesterday, GINA would not have been passed in 2008, but for being in the right place at the right time with Senator Bob Bennett. And then I helped him reach out to, because he had the disease, we recruited him on the PKD board, and then reaching out to a very influential Senator Orrin Hatch, who I had a great relationship with. And within four months, GINA was passed over the head of one senator, Tom Coburn of Oklahoma, who had held it up for 9 years. And that's, I haven't worked as much in the regulatory area, but I'm sure it works the same way as members of Congress. So it works. We just need to engage. Yeah. We need to get access or a way to reach out to this larger community. I think it's great what we've got, but there's got to be a multiple of that community out there, like has been stated.
Maybe, part of the process is, patients going on social media and asking other patients to connect with them, would be the way to do it, so that it doesn't involve, you know, the physicians cannot give out information, obviously. And so that's why, you know, it has to be amongst the patients themselves that they somehow self-organize, right? And we just encourage you to do that and advocate also to Congress or, you know, everywhere about rare disease. And what Marie said earlier about making sure that kidney disease is redefined based on genetics, especially these rare kidney diseases, officially through the Health and Human Services Department, CMS, which is part of that, you know, and how they code for kidney disease, which, because it will translate into how all of our nephrology colleagues around the country are going to understand kidney disease. And in many countries, there's the same process of trying to, you know, redefine diseases based on genetics so that we can, you know, make progress.
No, I think that's a brilliant idea. In fact, going back to the 4 legislative or members of Congress calls that I had, 3 were with the senior legislative person, 1 was with that person and the member of Congress. And in all 4 cases, I took the approach of, instead of just give us more money, give us more funding, and again, I was part of a broader rare disease group, I used the example of dialysis and how it's the #1 most expensive single line item in the federal budget, specifically under Health and Human Services. And they started to listen. I said, if you want to reduce this, this will more than fund what we're trying to, you ought to put it into innovation. You ought to put it into, you know, NIH. And boy, they were listening. They don't know that message, which is such an obvious one. It's a powerful message, but anyway.
My suggestion would be that the ADTKD Patient Foundation collaborate with the PKD Foundation on this, because the PKD Foundation also has great links with Washington and regulatory agencies, often through patients and CEOs and that, and then that the 2 organizations would seek for the genetic information to be anonymously available through the United States Renal Database, hopefully.
You know, that's, Marie, that is, or Dr. Hogan, that is a terrific suggestion. I used to be on the PKD board for 6 years when I thought I had PKD. And obviously we work very closely there with the Mayo and your colleagues. And I know those, you know, they may have turned over in the last few years, some of the board members, but they have a very effective group there. But frankly, no one in the kidney world has a compound that is moving towards the FDA for approval for a real treatment than the BROAD, than us, than our group. So, you know, as important work as PKD did, our, you know, not ultra rare, but our rare disease area of MKD, or it's the MKD, or we really ought to collaborate on one title, one term. I get confused by that, but we really should be collaborating with these larger organizations. We have
PKD, Richard, is also considered.
Thank you.
It's also considered a rare disease, and the tolvaptan approval was based on that sort of understanding of PKD or subsegmentation. You have a lot of reasons to be aligned. I agree with Marie, with the PKD folks, because, you know, genetic diagnosis of kidney disease, you're aligned on that. Need for treatments, you're aligned on that. Need to, you know, improve on dialysis or, you know, do things before people need dialysis, you're aligned on that. The length of the disease and the fact that it runs in families, you're aligned on that. So I think there's a lot of commonality that you could build on. And there may be more power to more voices added together. So, and from the nomenclature perspective, it seems like PKD for polycystic kidney disease, MKD for MUC1, and UKD for uromodulating kidney disease might be a way to kind of bring patients together. MUP, you know. It's hard, it's an alphabet soup, but, you know, I think defining it by, in your case, the UMOD and the MUC1 by the gene is to your advantage. You know, we should define the diseases, I think, based on the genetics, because that's the argument we're making, right? That we want to have the regulatory agencies and the government really see the diseases as defined by the genetics, and therefore the need for targeted treatments for those genetic causes, right? So, yeah.
Doesn't the compound work in both of these two?
We believe from the data that we have so far that the compound works for MKD and UKD, UMOD, yes. So we want to pull two diseases together. Obviously, it's not going to work for PKD, but there are many other areas in which your interests are aligned, and maybe you could have a louder voice in joining forces. Or, you can try to first identify more patients who are willing to add their voices to your cause within the US and Europe, Australia. All the colleagues who have been on this call have patients in all these countries. So I would say, maybe there's an opportunity there as well. And I think maybe Facebook would be a place to go for that. From what I hear from patients, that seems to be a place where people come together, or Twitter, places like that,
Do you have a social media person? Do you have someone that's doing social media? Because there's people that are just expert in that now, that are just invaluable.
Yeah.
I think Drew, who's missing at the moment, he had to drop off, is really the person who could help with the social media part of this, because he set up the website for the foundation. So we'll have to make an action item for him, Catherine.
Yep, I'm connecting with him.
I got that. I'll pass it along.
Great. So we have three, so far to summarize again, we have a few minutes left, 3 working groups, one on the registry, spearheaded by Catherine and Kendrah, one on biomarkers. Catherine is also the point person for that, but it will basically be our group at the Broad, together with Marie, together with Tony, together with Greg in Cyprus, and anyone else who wants to join. Just email Catherine and tell her you want to be in that working group, and we'll make it happen. Anywhere in the world, no matter where your institution is, what you want, everyone is welcome. And then the third action item, it's not really a working group for the doctors or the scientists, but it's more for the patients, is your work for the next 6 months is to, do more to either connect with the PKD Foundation or build more relationships with other patients, and maybe have more of a social media presence in the hopes of recruiting more patients to the cause. That could be an action item. Other items then, from beyond these 3, from anyone. We've had a lot of discussions the last couple of days. We potentially will have to sort of think about this, but maybe have the working groups have quarterly calls, and then maybe at the half-year point have a joint call where the working groups report back. Maybe that's one structure. Any other structures that people can think of or propose? We have consensus maybe that this sounds okay as a plan. That sounds good. So basically, it's up to each and every one of us to nominate ourselves to be part of each of the 2 working groups, or not, and just join the big half-year meeting in half a year, and then the summit again, hopefully next year, maybe in person, maybe virtual. We'll see. It seems that seems like a good way to organize ourselves at the moment, but we can always change it up. It's kind of up to us how we want to organize ourselves for this next steps. Any other comments, thoughts, ideas, suggestions from anyone?
This is Suzanne Kelly. I'm a patient. I couldn't raise my hand before, but I'll get in touch with Drew. NEF Twitter has a huge presence. They've got so much going on, so I don't know if there's anything that can be done there, but I'll touch base with Drew. I'll send him an email.
That sounds terrific, Suzanne. Thank you. Yeah, anything you can do grassroots is going to help a lot. So, and Twitter, from what I understand, is sort of a great place to bring people together. So that's great. Great idea. Anything else? Well, if not, then Tony and I, and I'll, maybe let Tony say a couple of words too, but just from my perspective, it's been a tremendous honor and pleasure to be with you the last couple of days. Just a couple of years ago, I think it would have been unthinkable to bring so many people together, patients, physicians, scientists, to work on a problem, and to even have the hope that there's a therapy around the corner. But I think we are here. That's our reality, and it's tremendously exciting. I'm also humbled by the mountain of work that we have ahead of us, but all together, I think we can accomplish something great here for our patients and for this community. And so, again, it's been an honor and a pleasure. I want to thank each and every one of you for participating, for your questions, for your enthusiasm. And I hope that we can maintain this momentum as we move forward with this project. So on behalf of a grateful and very busy team at the Broad, I will say thank you to all of you for participating these last couple of days. Tony, would you like to close us out?
Thank you, Anna. It was great, and I totally agree. Very excited about the future. It gave me a lot of ideas, and I'm looking forward to collaboration with everybody. So we'll see you again, hopefully in person pretty soon. Let's hope for that, and be in touch. Take care. Bye-bye.
Goodbye, everyone. Thank you very much.
Thanks a million. Great.